Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clonit, serving as the allocated session assistant to ensure a seamless experience. Clonit proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride the Clonit serves as a junior partner for this event hosted by Association of Fellow Gynecologists Mumbai. And the focus of today's session is RAN Symposium. Now, I would like to welcome Dr. Vidya ma'am for the further proceedings. Over to you, ma'am.
Thank you, Rimpa. And good morning to all our faculty as well as all the students. Rimpa, can I share now?
Sure, ma'am.
Yeah, so welcome all to the second AFG RAN Symposium. We have with us a huge expert faculty, including guest faculty with Dr. Reena Vani and Dr. Trupti Nadkarni, adding in their mind to the case studies for all the students to do well. And our whole mission for the symposium is empowering postgraduate students for exam excellence to restart, reinforce, and rise, focusing on their core concepts. We want to strengthen them, enhancing their clinical reasoning, structured exam preparation, and building confidence for the final assessment. So all the very best to all our students who are here today. And today's session, we are going to start it with Dr. Anurag Bhati addressing the whole session to begin with. And we have two case studies and one specimen by Dr. Jignesh Kansaria. The first case is by Dr. Yomika Bagil on PIH and preeclampsia. And we have our expert panel with Dr. Reena Vani. She is a professor and head of Department of OBGY from HBT Medical College and Dr. R.N. Cooper Hospital, Mumbai. And she's also a postgraduate and undergraduate teacher for DNB, DGO, MBBS, and an examiner for MRCOG. So I welcome her. Along with her, we have Dr. Trupti Nadkarni from the Nauroji Wadia Hospital. They both are examiners, and so it will give us a lot of input. And our seniors who are here, Dr. Saraugi, Dr. Mohan Gadam, Dr. Rajkumar Shah, Dr. Karthikeya, Dr. Motwani, all of them are here with us, and they've always been student friendly. And I think today is going to be great with all of them being present. So let us start with the first case. We have Dr. Yomika. Are you around, Dr. Yomika?
Yes, she's there.
She's there. Yeah, Dr. Yomika?
Yes, ma'am. Yes, ma'am.
Yeah, I will now take the sharing and you start off. But before I leave, my special thanks to all the faculty who have joined in. Thank you so much. Before we start, a small address from Dr. Anurag Bhate. Can you just...
No, you can go ahead.
Okay.
I just welcome you all on a beautiful Sunday morning. It's always a pleasure to sit at home and get involved in such a academic feast. So I welcome all our faculty, guest faculty, and thank you, Dr. Vidya and Dr. Jignesh, for this second RAN symposium. Your hard work is really reaping good efforts. Thank you.
Thank you, sir. Thank you. Yeah. Over to you, Yomika.
Yes, ma'am.
Yeah.
A very good morning to all the dignitaries and my senior faculty members. I am Dr. Vyomika Baghel, final year junior resident from Nauroji Wadia Medical College, Nauroji Wadia Medical Hospital. I'll be starting my case presentation on preeclampsia. So I'll be sharing the screen. Yeah. So my patient, Mrs. XYZ, is a 30-year-old female, married since 10 months, belonging to a non-consanguineous marriage, resident of Parel, Mumbai, who's a graduate, homemaker by occupation, primi gravida with a spontaneous conception. Her last menstrual period was 18th of September 2025, and her expected date of delivery, as per the Nagli's formula, considering the regular cycles, was 25th of June 2026. So Mrs. XYZ, she's a primi gravida, 35 plus 6 weeks of gestation, known case of chronic hypertension, came to a routine antenatal follow-up to the OPD and was detected with
Yomika, just a minute.
Yes, sir.
Yomika, please start on slide share. We're only seeing the part of it. We are not put on the slide share, have you?
Yeah, make it a complete sharing.
Large screen, full screen.
Okay,
Full
okay,
screen, yeah.
Full
Just
screen, yeah.
Is it like that, sir?
Not yet.
Yeah,
Okay.
yeah.
Got it.
Now that is good.
Yeah. Okay. So my patient is a primary gravida, 35 plus 6 weeks of gestation, known case of chronic hypertension, came for her routine antenatal follow-up to OPD and was detected with incidental high blood pressure readings. On presentation, she had no active complaints except sore throat since 1 day, and patient was already on antihypertensive therapy that was labetalol 200 mg TDS. Otherwise, she had no complaints of pain in abdomen, epigastric region, headache, nausea, vomiting, blurring of vision, leaking or bleeding per vaginum, fever, or even decreased fetal movements. She was advised admission for further management and evaluation. Coming to her obstetric history, this was her first pregnancy, which is spontaneous conception, and she registered with us at 12 weeks of gestation. Coming to the history of present pregnancy, first trimester, it was a spontaneous conception, and she registered with a private practitioner before us. Pregnancy was confirmed at around 7 weeks, 4 days of gestation by ultrasonography, and antenatal profile was done, which was noted normal. She had taken folic acid supplementation and was diagnosed with chronic hypertension at 8 to 9 weeks of gestation, and started on tablet labetalol 100 mg BD and ecosprin, that is aspirin 150 milligram HS.
Yomika,
Yes, sir.
can I just interrupt? She is a known case of chronic hypertension, right?
Yes, sir. Right, sir.
And she was already on labetalol 200 milligram twice in a day.
100 milligram. Yes, sir.
200, I think your previous slide says 200 milligrams.
So that was when she came to us, which was stepped up later. But in the first trimester, it was started with 100 milligrams twice a day.
What was the blood pressure at that time?
Sir, in initial readings, her blood pressure was around 150/100 in the previous her OPD follow-ups, which was with a private practitioner, and it was noted around 150/100. So she was started with labetalol 100 mg BD at that time.
And so 100 milligram BD is enough dose?
Yes, so for the starting dose, I would start with 100 milligram BD. And
No, but she must already be on labetalol, no?
No, sir. Initially, she was not. Actually, before this, she had a prior history of raised blood pressure before her pregnancy, and she was not taking any medication for that as such. So after conception, she was started on antihypertensives. Before that, she was not taking any drugs.
Okay, and aspirin 150 milligram.
Yes, sir. Right.
Why?
So that's the standard dose which we usually start for prevention of
Vyomika, this is
Yes,
Dr. Vani. What is
Yes, ma'am.
the recommended dose of aspirin for prevention?
Ma'am, as per the ACOG guidelines, it is 81 milligrams, and as per the RCOG guidelines, it is around 75 to 150 milligrams. And as per the class studies, it suggests that a dose more than 81 milligrams is better compatible with the use of aspirin.
What are we giving? What is
Sorry, ma'am.
you're aware that there was a FOXY ICOG guideline which was released at this national conference. In that, a lot of
Yes, ma'am.
I would recommend all of you look at the FOXY website and download it. It's for free. But basically, as based on the aspirin trial and a lot of the studies, 150 milligram is what was recommended by most of the studies. The doses range from 81 up to 75, which is what people are using based on the country from which the reference is taken. So we should
Right,
say what we are giving. So in my hospital, we have now started giving 150 only. So what are you giving? Oh, you have written patient.
Ma'am, 150. Yeah, we give 150.
Correct. So that is the dose. What is a better time to give aspirin? After lunch or after dinner?
Ma'am, at bedtime, yeah, after dinner.
Yeah, actually, most of the studies have been done with after lunch dosing, and they say that is better. And supposing she goes into labor or something, how many days do you need to stop the aspirin?
Ma'am, at least 48 hours.
Yeah, a lot of people feel for 1 week. So good. Carry on. Good.
Yes. Ma'am, besides that, in the first trimester, her dating and NT-NP scan was done, which was noted normal. And her dual marker test was suggestive of low risk for aneuploidy of trisomy 21, 13, and 18. Besides that, ma'am, we did her all antenatal profile. Besides all antenatal profile, we had done her routine tests of CBC, LFT, KFT, urine routine, protein creatinine ratio, 24-hour urinary protein. All of them were noted normal in the first trimester. And even the end organ.
Slide, I have one more question for you.
Yes, ma'am. Yes,
she was diagnosed as chronic hypertension at 8 to 9 weeks.
Right, ma'am.
It's good that you all have started on labetalol. Sometimes we get patients of chronic hypertension or pre-existing who have come to us on certain medications. Which are the medications which we need to change in pregnancy?
Yes, ma'am.
Even
Ma'am,
it's well
if a
controlled.
patient is already on drugs like ACE inhibitors or maybe ARBs, we need to switch over to labetalol.
Yes,
Even if
why?
a patient is taking amlodipine, we switch
Why?
over to labetalol.
The ACE inhibitors and the ARBs, why are they
Yes.
not recommended in pregnancy and lactation?
Ma'am, ACE inhibitors are known to be teratogenic, and it has a substantial. There are studies that it shows a substantial risk of IUGR, oligohydramnios, and maybe even renal anomalies.
Specifically, yeah, kidney-related
Anomalies.
have been detected, which is why
Yes, ma'am.
we don't use them. And if they're
Right, ma'am.
already on that, we switch to something
Yes,
better.
ma'am. Yeah, we switch over.
Carry on.
Yes. Then, ma'am, we had done her CBC, LFT, RFT, urine routine microscopy, urine protein creatinine ratio, 24-hour urinary protein, and all her end organ workup was done, including the ECG, 2D echo, fundoscopy, and USG abdomen. Besides that, there was no history of. Yes, sir. Yes, sir.
Urine
You
protein
also mentioned
creatinine ratio, if you have done that, is it necessary for you to do 24 hours urinary proteins?
No, sir, not necessarily, because urine protein creatinine ratio is as accurate as 24-hour urinary protein.
So what is the pathological level of urine protein
Sorry,
creatinine ratio?
So for urine protein creatinine ratio, it should be more than 0.3, which suggests of proteinuria and would be giving us a diagnosis of preeclampsia if it is more than 0.3.
So in that
And
case,
for
you don't
24-hour
need to do
urinary,
24 hours urinary proteins.
right, sir? No, not
Right,
necessary.
that's great. Yeah. Okay, go ahead.
So besides that, there's no history of headache, visual disturbances, epigastric pain, reduced urine output, burning maturation, or excessive weight gain in the first trimester. So then coming to the second trimester, she had a total.
One
Yes, ma'am.
second, Vipika.
Yes,
You
ma'am.
talked about the NT-NB scan within normal limits.
Yes, ma'am.
Is there
Right, ma'am.
anything in this scan which sometimes when the radiologist gives us reports, anything that can raise a risk that this patient has a problem in the
Ma'am, in the NT-NB scan, like if we are looking for this patient, we might see for the uterine artery PI, which might be raised since
Yes.
she's a chronic hypertension. So if at this point of time we would have not started aspirin, we can start after doing the NT-NB scan if it is
So
raised.
this is something which you all should keep in mind, that here it is
Right,
a
ma'am.
uterine artery PI we are talking about, whereas
Yes,
in
ma'am.
the trimester, which is the artery we are imaging in Doppler
Third trimester, ma'am.
in third trimester.
Uterine artery
What
and
is the CPR?
cerebroplacental flow ratio, ma'am.
Does that use uterine artery?
No, ma'am. MCA, middle cerebral artery, and
Yes. Okay. Carry on.
yes.
Talked about epigastric pain. Why are you interested in knowing epigastric pain?
So epigastric pain is a sign of premonitory symptom which happens due to stretching of the Glissen's capsule and leads to epigastric pain in preeclampsia.
But what is the significance?
So if a patient is having any premonitory symptom in the first trimester, we can it can be a sign of impending eclampsia.
In first trimester?
Not necessarily. So usually it is not going to be present in first trimester. It's usually presenting in late second trimester and third trimester.
So you are actually dealing with chronic hypertension at the moment, since patient is
Right,
only
sir.
12 weeks pregnant.
Yes, sir.
Yeah, and the toxemia element, probably if at all it comes, it might come later.
Right, sir.
Yeah, so that's not of great significance. But what is in general, what does it signify? Like severe headache, epigastric pain, blurring of vision, or visual disturbances? What does that signify in a patient with pregnancy-induced hypertension or pregnancy-induced hypertension superimposed on, hypertension superimposed on chronic hypertension?
Yes, sir. Headache can usually be because of the cerebral edema. Visual disturbances can also be because of the edema in the occipital region, and it can be due to the reduced blood flow. Reduced blood flow because of the thrombosis, that the urine output will be decreased. And for the liver, for the epigastric pain, usually stretching of the Glissen's capsule, secondary to hematoma forming around the liver, can be a reason for epigastric pain, sir.
Yeah, so all these are signs of severe preeclampsia.
Yes, sir. Right.
Right?
Right.
Yeah, and what are the other signs of severe preeclampsia? A patient of chronic hypertension or preeclampsia going into severe preeclampsia.
Right, sir. So besides
What are the
that,
other signs?
Besides that, patient might have excessive weight gain. There might be pedal edema or maybe grade 2, grade 3 pedal edema.
But
there
that is
might
always there, no? In many patients, there is even physiological edema is there.
Yes, sir. We'll have.
No, but what are the signs which will indicate that you are going into severe preeclampsia? What are the levels of systolic blood pressure and diastolic blood pressures?
Sir, blood pressure more than 180 by 110 will be basically suggesting of severe preeclampsia.
180 or 160?
So 160, 110 is for a label, and for severe preeclampsia, it will be 180, 110.
And how often you need to take this blood pressure to label them as severe preeclampsia?
So every 15 minutes.
At least on 2 occasions, 4 hours apart.
Every 2 occasions, 4 hours will be for gestational hypertension.
So on 2 occasions, 4 hours. And how do you take this blood pressure?
Sorry, sir?
How do you take this blood pressure?
Yes, sir. So for taking the blood pressure, if we are taking it in the sitting position, we'll put we'll be attaching the BP blood pressure.
Why do you want to take? Why do you want to take blood pressure in sitting posture? Whether it is in supine, whether it is in left lateral, whether it is in semi-recumbent, and whether it is in sitting posture.
Sir, for any of the patients with hypertension, I would try to look for measure BP in 2 positions.
Okay.
One will be the sitting.
Why do we not take blood pressure in supine posture?
And one will be the left.
Especially when you're dealing with hypertension and preeclampsia or pregnancy-induced hypertension, why do we usually not take blood pressure in supine position?
Hello. Sorry, I didn't get you, sir.
Dr. Mohan, this is actually a question I also like to ask, but these youngsters don't believe. They have not heard of rollover test or supine hypotension syndrome. But especially if you get some old-time examiners like us, you better know it. What is the rollover test and what is supine hypotension, which is what you expect in normal pregnancy?
Yes, ma'am. Ma'am, supine hypotension will be due to the compression of IVC because of the gravid uterus that the blood pressure readings will come.
Correct. So in a normal pregnant woman, if you take the pressure flat on the back, it's going to be low. What happens in PIH, and that's the basis of the rollover test, which was one of the clinical screening tests for PIH, which was described. So tell us, You've not heard of it.
Okay.
Yeah. We move on.
Now, you see, the physiological response is supine hypotensive response in normal patient. But when this patient is in pregnancy-induced hypertension, there is a supine hypertensive response because the pressure substances are released as soon as the vena cava is compressed, and then there is an apparent increase in the blood pressure. So that's why you may not get the idea about true blood pressure. That's why take it in semi-recumbent or in left lateral or in sitting posture with the cuff and the sphygmomanometer at the level of the heart. Right? That is the principle.
The level of the heart. Right.
Okay. Yes, go ahead.
Yes. So then coming to the second trimester, she had a total of 5 visits in the second trimester, where she was immunized with 2 doses of tetanus diphtheria, and she's a history of hospital admission for cervical encephalage at 16 weeks. Which was done in view of short cervical length, which was detected on ultrasonography. After that, she had underwent her anomaly scan, which was done and noted normal. We had again done her routine investigations with CBC, LFT, RFT, urine routine microscopy, urine protein creatinine ratio, and 24-hour urine inputting, which were all noted normal. Her oral glucose tolerance test was done at 24 weeks and was noted normal. She felt she had a first sensation of fetal movements at 20 weeks, compliant with hematinics, calcium, and antihypertensive drugs and aspirins. She had no history of headache, visual disturbances, epigastric pain, reduced urine output, burning maturation, or excessive weight gain in the second trimester.
Okay, go ahead.
Yes. So then coming to the third trimester, she had a total number of 6 antenatal visits in the third trimester, and she was perceiving fetal movements well. She had sudden development of swelling over both feet, and history of odd investigations were done at that time, noted normal, and stepped up dose. Her antihypertensive drugs were stepped up to labetalol 200 mg TDS.
What is the maximum permissible dose of labetalol before you add on another drug? Are there any guidelines? What is the maximum dose?
Ma'am, ma'am, as per the guidelines, we can step up the oral labetalol to 2400 milligram. That is the maximum dose which we can give throughout the day in 24 hours.
That's
Oral
right.
labetalol.
Which
That's
are the
right.
patients?
That is as per ACOG
Yes.
guidelines.
Yes, but
Yeah.
which are the
Yes.
patients in which you will not be very happy to have high dose labetalol, or which patients you would prefer to use some other antihypertensive drug in pregnancy? One specific group. What is what kind of drug is labetalol? That will help you answer this question.
It's an alpha plus beta blocker.
Yeah, so patients who have COPD or asthma to start with are not
Yeah,
good
yeah, yeah.
candidates for labetalol, particularly in high
High dose, yeah.
doses. So in that, you would use alternative drugs. What are the
Yes.
alternative drugs for high blood pressure in the antenatal period?
Ma'am, we can use drugs like nifedipine, which comes as Nicardia retard. We can add on that drug, which is a calcium channel blocker. We can add hydralazine, which is a vasodilator. We can add
Yeah, okay, carry on.
What about methyl dopa? Yomika, what about methyl dopa? L-methyl dopa. We're not getting, not able, we're not audible.
Dopa.
Yomika, you're breaking. Hello?
Your voice is breaking, Yomika. Rimpa?
I think her internet must be weak.
Yeah.
She has to plug the video and start with the
That's right.
audio.
Can we use L-methyl dopa, Yomika? And can you combine L-methyl dopa with labetalol?
Yes, I think she's disconnected.
While they're getting their maybe you can answer the question, sir, while they're getting their internet in order. Yeah.
Everybody is able to hear me also?
Yeah, we can hear you well.
Yeah, Yomika, we can go up to around 2,400 milligrams of labetalol. One can add L-methyl dopa also. It has synergistic action. It has been tried and it has been used in India quite often in many centers and many consultants. And then you have nifedipine. So these 3 or 4 drugs are there which can be easily used for management of hypertension in pregnancy. And all other drugs which were used earlier, in case if they are essential hypertension patients, should be stopped 1 or 2 months prior, and especially when they are taking any fertility treatment, they should be advised because they are all, especially inhibitors like angiotensin inhibitors and all, they have teratogenic effects and hence should not be used in pregnancy and should be stopped much prior to starting any fertility treatment.
Another thing, for the students, while I think our students who are presenting get there, you have to remember that the choice of drug, sir talked about alpha methyl dopa. Alpha methyl dopa was one of the drugs used in the past very commonly, but unfortunately it is not available. So you have to also see the availability of drugs, the cost of the drugs, and the suitability of the individual patient. Okay, I think
Rina, it is available. Rina, it's available and it's the cheapest.
it is now available, sir, but in the middle,
Yeah.
a lot of the pharma.
Now there are different companies which have come up, and it's one of the cheapest drugs, much cheaper than labetalol.
Yes.
Yeah.
Even this hydralazine is now available as
Yes.
aerosol, which is also cheaper than, and 25 milligram twice a day. We have used it up to TDS, and it has worked very well for control.
Yes, that's good. Yeah, that's right. Yeah.
These are, I think, because most of the studies are from Canada and US, which recommend labetalol as the first line drug. We are
Yes.
following the West,
I
but
think,
we should think about our own indigenous available drugs also. I think Vidya, the 2 students have logged in. I think we can continue with the case.
Yeah, she's already here.
I just wanted to know, is there any role of calcium in prevention of PIH or preeclampsia?
High dose calcium.
Yeah, high dose calcium, yeah.
Good morning, Dr. Sarohi.
Yomika, unmute yourself. Yomika, unmute yourself. Unmute yourself.
Yes, ma'am. Sorry, ma'am.
Okay.
Yeah. Yeah. Yes, sir. There are studies that if we gave high doses of calcium of 1.5 to 2 grams per day, it has shown better uh, compatibility and lesser chances of preeclampsia. It has a role in prevention.
Vyomika, this is actually, you should answer more specifically. In calcium deficient populations, it
Yes,
has been found to be useful. Now,
okay, ma'am.
this in fact is one of the essential recommendations of WHO for pregnancy management, along with calcium, folic, along with iron, folic acid. This is a recommendation given way back in 2011 by WHO in essential
Right.
drugs in pregnancy. But the catch line is calcium deficient populations, because often in the West, they don't have that, hence it is not given as standard practice. But Sir has pointed out a very important thing, but this is for prevention. It is
Right.
not a treatment. Yeah. Continue.
Right. Ma'am, then in the second trimester, my patient had a history of hospital admission for
I think
blood
we
pressure
reached the
control.
third trimester now. We
Yes,
are
ma'am.
running short of time. Yeah.
Yeah, ma'am. Besides that, ma'am, there was a total weight gain of 13 kilograms in her pregnancy throughout.
So rapid
Um,
weight gain in pregnancy, is it a cause of concern? If so, why?
Yes, ma'am. Yes, ma'am. It can be a sign of preeclampsia because in preeclampsia or even gestational hypertension, there is development of pedal edema and it can lead to excessive weight gain.
ठीक. Carry on, carry on.
Yes, ma'am. Then, ma'am, next coming to the menstrual history, patient LMP was 18th of September 2025. Her periods were regular, lasting for 28 to 30 days, and with a moderate flow, no complaints of dysmenorrhea or passage of clots. In her past history, as I mentioned before, she had a history of raised blood pressure 6 months back. However, she was not started on any antihypertensive drugs as of then. When coming to her family history, it was not contributory. Personal history, she consumes a mixed diet, predominantly vegetarian, with no addictions and known allergy. She has adequate sleep and normal bowel and bladder control.
In family history,
Yes,
for
ma'am.
in PIH or preeclampsia, what family history would be relevant? Now, your lady has chronic hypertension.
Right,
So, is there a genetic basis of preeclampsia?
Yes, ma'am. Yes, ma'am. There's a genetic basis of preeclampsia. I would ask of preeclampsia in her mother or her siblings, or maybe even her father if he has chronic hypertension.
No, when you
Genes
say
like
there is a genetic
HLA-DR4.
basis, you have to be more specific. What is it, and in which side of the family? What type
Ma'am,
of
mostly the
genetic
maternal and the
inheritance?
paternal both will ask. Mostly in the maternal side, I'll ask
Yeah.
if there's history of any preeclampsia in her siblings, elder sisters or mother.
Yeah, ठीक है. Okay.
So is the gene coming from mother or from the father?
Sorry, sir.
She said, sir, that maternal history is more relevant, mother and sister. Yeah,
Yeah,
carry
that's
on.
correct.
Yeah.
So then coming to the examination point, patient is comfortable at rest, conscious oriented to time, place, and person, and was examined in supine with left lateral tilt with legs flexed at hip joint. My patient has an average build and is adequately nourished. She's a height of 166 centimeter and weight pre-pregnancy was 67 with a pre-pregnancy BMI of 25.5. On examination, her vitals were around. She had a pulse rate of 90 per minute, 90 beats per minute with a regular rhythmic euvolumic pulse. Our respiratory rate of 18 breaths per minute and blood pressure of 180 104 millimeters of Hg left arm in sitting position and 176 by 100 millimeters of Hg left arm in left lateral position. She had mild pallor and bilateral grade 2 pedal edema was present. Otherwise, there was no icterus,
What are the
cyanosis, or
grades of
lymph.
edema? This is also a very standard exam question. What
Right,
are the
ma'am.
grades of edema?
Ma'am, if the pedal edema is localized at the level of ankle, that will be grade 2. Above the ankle, it will be grade. At the level of ankle, it will be grade 1. Above the ankle, it will be grade 2. Above the knee, it will be grade 3. And overall, if it is
My
anasarca,
dear,
grade 4.
above the knees is not where do you elicit edema is on a bony surface. So
Bony surface, yes, ma'am.
it is at grade 2 is pre-tibial, and
Yes, ma'am.
grade 1 you on the malleolus. But grade
medial
3
malleolus.
is edema at two independent sites. This is a very common mistake made by students in exam. That's why I asked this question.
Okay.
Above the knee, you cannot press on the thighs. You will never be able to pick up edema. It is at two independent sites. For example, over the sacrum or abdominal wall edema along with pedal edema, then you would say it is grade 3. And what is grade 4?
Ma'am, grade 4 will be anasarca, like overall.
Yeah, which is generalized edema. Fair enough.
Generalized. Yes,
Okay, fine. And another very common exam question in practicals is, what is the differential diagnosis of edema feet in pregnancy? One is, of course, your PIH, but quickly list 2-3 causes.
Ma'am, first will be physiological, second can be secondary to anemia. It can also be secondary to some renal conditions if a patient is a known case of some renal disease, or maybe some cardiovascular disease.
Okay, fine. She's listed most of the conditions. That's fine.
Yes,
Vidya, how much time do we have? We will time our questions accordingly.
Yeah, madam, we have another 25 minutes.
25 minutes. Okay.
Minutes. Okay, Yomika. And what is gestational edema?
Sorry, sir.
What is gestational edema?
Sir, in gestational, that is a physiological edema. It is usually present in the
gestational edema is not physiological edema. It is pathological. It's a variant of preeclampsia. Are you aware of this?
No, sir. As such,
Edema of more than grade 2 in spite of 24 hours of bed rest.
Okay.
Gestational edema, and or there's no edema but a weight gain of 5 kgs in a week.
Okay, sir.
Again, points towards gestational edema. It's a variant. These are the patients who are likely to go into preeclampsia sooner or later.
Okay, sir. I was not aware about that.
Okay, go ahead.
So then coming to the systemic examination, cardiovascular system S1, S2 beats were heard, no added sounds were heard. Respiratory system, air entry bilaterally equal. Coming to the obstetric examination, the patient was examined in supine with left lateral tilt. On inspection, her per abdomen, her uniformly distended abdomen was noted. Umbilicus was central and inverted. Linea nigra was present. Stria gravidarum was present. On palpation, uterus was corresponding to near about 36 weeks with a symphysis fundal height of 35 centimeter. There was no uterine activity, and Liker seems adequate on palpation.
What is McDonald's rule? What is McDonald's rule?
Sorry, ma'am.
What is McDonald's rule?
Ma'am, McDonald's rule is used to calculate the estimated fetal weight as per the symphysis fundal height.
No, that is Johnson's formula. McDonald's rule is fundal height in centimeters into 8/7. This is also a very old-timer standard question, but a lot of the youngsters are not aware. You eat the burgers, so remember McDonald's. 8 centimeters into 8/7, and Johnson's formula is the one which is used to calculate fetal weight. Yeah, continue.
Yes. Okay, ma'am. Ma'am, on the examination, Leopold's first grip, there was soft, broad, irregular, non-ballotable mass felt, which was suggestive of breech. On the second grip, a smooth, curved, uniform resistance felt, which was suggestive of fetal back on the left side. And Leopold's third grip, there was small, knobby, irregular parts were felt on the right side, suggestive of fetal limbs. And on the fourth grip, there was head was felt, which is not engaged. Then coming to the auscultation, fetal heart sounds were heard on the left side, which were regular of 130 beats per minute. And then coming to the pervaginal examination, cervix was soft, posterior, os closed and uneffaced. We did her urine albumin dipstick, which was +1 with no premonitory symptoms, and bilateral knee jerks were normal. Coming to the provisional diagnosis, my patient is a primary gravida, 35 plus 6.
Sorry, 1 minute. This urine albumin testing, what is now the standard practice? How do you test it in the outpatient department? And up to how much is considered physiological?
Ma'am, we usually at our place we usually use the dipstick method, dipstick urine albumin test, and till trace can be considered physiological. Above +1 will be considered pathological, ma'am.
Dr. Reena, you need to unmute.
What does it correspond to in milligram per deciliter? +1, +2. So you should know that up to 300 milligrams in 24 hours is considered to be physiological.
Right.
And what was the method? It is still used in some OPDs where you put a drop or something.
Ma'am, we put 5% of sulfosalicylic acid in the urine.
Yeah.
Same
now
amount.
That, of course, is the old method, but it is still used in some areas, so you should be aware. But yes, dipstick is the one which is used now. Yeah.
Yes, ma'am.
Yomika, this +1 urine albumin, is it significant?
No, sir. As per the ACOG guidelines, it is considered as significant, and as per the RCOG guidelines, it is +2, which is considered significant.
Yes.
Yeah, ACOG as well as RCOG, I think it's +2, which is significant. But another important thing is if is this urine albumin likely to be present right from the beginning? Because since this is the patient of chronic hypertension.
No, sir. In the beginning, it might not be present. It will only come if there is superimposed preeclampsia.
So do you mean to say that patients with chronic hypertension do not exhibit urine albuminuria?
No, sir. They might, but it will be in the physiological range, not in the pathological range.
So less than 300 is physiological range.
Right, sir.
+1 is less than 300. More than +2 is more than 300.
More 300, right, sir.
Yeah. So this is in physiological range. So this still could be present because this is the case of essential hypertension. So that's one of the diagnostic features that often you label these patients as preeclamptic toxemia or preeclampsia because they have hypertension, they have urine albuminuria, or they have edema. So in that case, you may be actually mistaken because many patients of essential hypertension will also have +1 urine albumin.
Right, sir.
So that has to be kept in mind. So you have to look for other signs and pathological features and laboratory investigations to find out whether this particular patient is going into preeclampsia. Because preeclampsia superimposed on essential hypertension will have different picture as far as maternal morbidity mortality and fetal morbidity mortality is concerned.
Right, sir. Right.
Yeah. Okay.
Yes. So then coming to the provisional diagnosis, my patient is a primary gravida, 35 plus 6 weeks of gestation with chronic hypertension with superimposed severe preeclampsia with cervical stitch in situ. I'll come to that.
She is 36 weeks pregnancy, right?
Yes, sir. 36 weeks.
I'd like you to add a little bit when you give your final diagnosis.
Yes, ma'am.
That with single, in your 35 weeks, 6 days with single live fetus, longitudinal lie, with chronic hypertension, with now on what basis you are saying superimposed severe preeclampsia? I want you to justify that later, but you need to specify with no other complications. Now, why did you say superimposed severe preeclampsia?
Ma'am, because her blood pressure readings were above 160, 110. Her systolic blood pressure was 180 consistently on 2-3 readings, which we took 15 minutes apart. So I would label it as a severe preeclampsia, case of severe preeclampsia.
Okay.
Right. Yeah, that's right. Yeah. Okay. And what else? As Dr. Reena is saying, any other feature important? I think this is breech presentation, right?
Cephalic presentation, sir.
Was it? Because your findings are suggesting breech, I think.
No, sir.
No?
No.
I think, sir, she had given findings suggestive of floating
Somewhere
head.
it is mentioned breech.
No. Yeah.
Okay.
And another, head was not engaged. It was cephalic, sir. She had given that.
Yes.
Another thing about per vaginal examination.
Yes,
sometimes you are asked this question that in your case, is PV required? If yes, why? If no, why not? So in this case,
very right.
what is the role of the per vaginal examination and or per speculum?
And for her case, per vaginal examination might not necessarily be needed because she's a case of severe preeclampsia covering with a gestation age of almost 36 weeks. And I would rather take her for immediately emergency lower segment cesarean section rather than giving her trial.
Why?
No.
Why cesarean section? Why not trial?
I am sorry, I disagree with you, dear. In fact, in most PG cases, unless there is a placenta previa on the history or this, you should say for the management plan. One thing in this patient, she also has a cervical stitch with severe preeclampsia and short cervix. So, and she's also on aspirin. You would say you would first do a per speculum examination, look at the status of the stitch, rule out any infection, look for any bleeding, and if required, consider cutting the stitch on speculum examination. Often they go into labor. In fact, for the woman, a vaginal birth, even if it is that concept of 0-hour section for preeclampsia and eclampsia is out. You have to try to stabilize the maternal condition. Yes, you won't have a very prolonged trial for her, but
Right.
if you manage to deliver her vaginally, she's going to be much better off. So
Better.
you would like to assess the cervix, do a bishop score after cutting the knot, and then
Yes.
have your management
Right,
plan in place. That's what you should have answered.
Yeah, right, ma'am. Actually, I forgot to mention the first speculum examination. Yes, ma'am. Right. You are
Yes.
absolutely
Okay. Yeah. Carry on.
And
So
as such, also this patient is likely to have a short labor because she has incompetent os, and the baby also is
Competent os.
less likely to be
Right.
large for gestational age. So baby also may be small. So she can, if you can really monitor
Okay,
and
now
give.
supposing you, Vyomika, with
Yes,
you
ma'am.
have the backing of your seniors who have said, Chalo, we will try. For induction, what would you use, and what are the drugs which are going to interfere with your induction? What do you have
Ma'am,
to do? Yeah.
Ma'am, for induction, I would prefer her bishops is really poor, but for any case like that, I would prefer Foley's catheter as a method of induction, which is a mechanical method, rather than giving misoprostol or even dinoprostone gel, because it can somewhere lead to hyperactivity or hyperstimulation.
Well, in this, one thing you have to remember, you have to talk about, she's 35.6 weeks, so it's okay. But what about the role of prophylactic magnesium sulfate? Do you think?
Yeah, ma'am. Yes, ma'am.
No, for two things. One is for prevention of convulsions, because you said she had superimposed severe preeclampsia.
Right, ma'am.
And what about neuroprotection and this? And secondly, if you have added on nifedipine, you have to remember that was the second part of my question. That when you're trying to induce labor or have a vaginal birth, the problem is if you're giving high doses of nifedipine along with magnesium sulfate, they have a synergistic action and they both are uterine relaxants. So on one side, you're trying to get her into labor, and the other side, to control her blood pressure and prevent convulsions, you're giving medications which are causing a problem for her to deliver.
Right.
So that balance is very important. So you have to choose accordingly.
Right, ma'am. Then for her case, since she's more than 34 weeks, I would not give a magnesium sulfate neuroprotective dose, but I can give her magnesium sulfate as a anticonvulsant therapy by either Pritchard regime or the Zuspan method.
Correct. In fact, Pritchard regime is a time-tested one, and if you are giving her a trial of vaginal birth, giving the Pritchard regime, some people modify it and omit the IV dose. You can give at least the intramuscular dose. There are not enough studies or scientific data on this, but definitely considering Pritchard regime, which will give for all some benefit of neuroprotection may be there, but we don't give it in the neuroprotective dose. And you will make vigorous efforts to induce labor based on the Bishop score. Now, if you're using ARM with oxytocin, what is the important thing about use of oxytocin or this once the cervix is 2-3 centimeters in a case of severe preeclampsia? What do you want to avoid?
Ma'am, after doing the ARM, I would stop the oxytocin right away because it might lead to.
Not at all. In fact, what the point I was trying to emphasize is that there is a risk if you start oxytocin, especially if you feel that there's a chance of abruption. She was on aspirin and other things. Doing an ARM before you start oxytocin is always advisable. Otherwise, sometimes you land up with a concealed abruption, which can trigger the DIC. As it is, this is a patient who's prone to HELLP syndrome.
Right,
so it is. So these are certain practical points. See, this whole point of this case discussion, it's not a seminar. That's why I'm trying to ask you practical questions. We are not here to discuss the theory. So you have to talk like a consultant in your exam that what you actually do. And so you tell me now, you are a consultant in the nursing home. You have nobody around to back up. How would you manage this patient if her BP was 180, 110? She is on labetalol 200 TDS. She has a short cervix with a stitch in place. Her blood parameters you've given. Now to answer the question, at 35.6 weeks, what will you do with this patient? First of all, will you give steroids or not? You have not talked about that
Yes,
at all.
ma'am. Yes, ma'am. I will give her steroids. But for her case, this patient was already steroid covered, ma'am. But otherwise, I would give her the first dose of.
If the patient has not been covered with steroids, you will give the first dose of steroids while stabilizing the patient and this. Okay,
yes,
next.
Yes, ma'am. Ma'am, then I would give her the appropriate antihypertensive therapy. Either I will step up the dose of labetalol or I can add Nicardia, that is nifedipine, for this patient. and see if the blood pressure is controlled. If
What
not,
is the
then
role
I
of
would.
intravenous medication
Yes,
in
ma'am.
such a case?
If it
BP.
all, after giving her oral medications, if it is not controlled, I would consider IV intravenous antihypertensive therapy. I can give her labetalol 20 milligrams IV slowly, and we can monitor her blood pressure every 10 minutes, 10 to 15 minutes, and we'll repeat the dose of labetalol as per her blood pressure readings. If required, I can double the dose.
Up to how much can you give in 1 hour of IV labetalol?
Ma'am, I'll double the dose to
Up
20.
to 80 milligram you can give IV
Within 1
hour. Within an hour in regular boluses. But
Okay.
I mean, controlled bolus injection. And
Right.
you have to say that if she's already on the medication, what should you not do with nifedipine? Do not give sublingual, because in
Right, ma'am.
non-pregnant patient, this also should come out in your discussion. In a
Yes.
non-pregnant patient, we often give sublingual to control the blood pressure,
Blood
but it is
pressure, yes.
absolute no-no in pregnancy. Why?
Because it can lead to sudden hypertension.
Sudden hypotension can cause fetal demise and cause a problem in the mother. So all the guidelines have said it is not to be given sublingual.
Yes.
There is also IV hydralazine available. So as an obstetrician in the labor room, these are the only two which we will consider. Anything worse than that, ideally patient should be shifted to MICU. These are also in a lot of the guidelines, that if the initial management, she is not getting stabilized, the further stabilization of the patient should be done with an ICU setting. If you're considering other things like an NTG drip or emergency stuff like that, patient has to be in the ICU. And then you do your obstetric management. Supposing you've decided now that for whatever in this, she needs a section. Yes. Will you give her the full dose of Pritchard regime before the section? If you have decided now that, oh, I don't think she's going to deliver, I am taking her for LSCS now. So by the time your anesthetists come and all, it's going to take about half an hour. Do you want to give the Pritchard regime now? Yes or no?
Yes, ma'am. I still give her the loading dose of Pritchard regime, ma'am.
It's a bit of a dilemma. I'll tell you why. I am in two minds for this. You would have to be careful, because especially if you're giving general anesthesia, sometimes if you've just given the entire loading dose of Pritchard just before you take her up for section, the reversal of GA becomes very difficult. So if you've decided to take her up for section, unless she's already convulsed and all, prophylactic Maxulf, you have to think twice based on the situation. If she's already a case of eclampsia, she has convulsed, it doesn't matter. Yes, of course, you're going to give the full dose of the Pritchard regime. These are the finer points which are points which come up for discussion in a PG case. Now, again, if you're doing you were very keen to do section in this patient right at the onset. So what anesthesia would you want for this case?
I would prefer a spinal anesthesia for her. Spinal plus epidural at max.
You would prefer spinal with epidural. But what is her platelet count?
Her platelet count was adequate, ma'am, around 150.
So if the platelet count is adequate, yes, regional anesthesia is a good option. Supposing her platelet count was 75,000.
Then I would prefer, ma'am, general anesthesia for her.
Either that or also other factors. Now, what are the problems with general anesthesia in severe preeclampsia? This is also a very specific thing which you have to be aware of. What are the problems of GA? If there's an anesthesia complication and death, as the obstetrician in charge, you are going to be liable. So you should know about this. Yes, answer my question. When you are intubating, there are hypertensive responses and the BP and the pulse tends to go up. So in fact, often they spray lignocaine or something on the vocal cords before they put in the tube. In fact, it's a documented hypertensive response to intubation. So you have to be very careful. Another thing is there's often edema of the vocal cords and the glottis in a patient who's having a very severe preeclampsia. So it is usually a difficult intubation. If these patients are edematous, short, obese, her BMI was high, she may have a short neck. Again, there's a Malampatti classification of intubation for the anesthetist. They become high risk for intubation. So these are all factors which have to be kept in mind while choosing. So your answer was correct. If the platelet count is good, it is much better to do except if the patient has already gone into early help syndrome with DIC. In those situations, I myself prefer that they are done under GA and sometimes take a vertical midline incision for the section. If she's already in incipient help, you'd give her blood products and other things. And then, of course, again, it's a personal choice how some things depend on the consultant. Yeah.
Right.
Dr. Gadam, Dr. Rajkumar, आपको पूछना है कुछ?
Yeah, so I would want to impress on what is the urgency of management when the blood pressure is 180.
Yes, sir.
What are you worried about?
Sir, it can if there's it is basically a sign of hypertensive crisis, and it can lead to impending. It is a sign of impending eclampsia, as to why I have to immediately manage the case.
More gruesome is something which can cause intracranial bleed.
Yes.
So it is important, especially
not
in the
only
patient of
bleed, but it is
preeclampsia.
hypertensive
patient-
encephalopathy.
Right.
So there is hyperperfusion of the brain, and therefore, there's a possibility of development of this intracranial bleed. So it is important that the blood pressure be brought down at least up to 160. The target for bringing down the blood pressure is not more than 30 millimeters at one point of time.
Right, sir.
So it is important to impress this audience that bringing the blood pressure down to below 160 is important, because it will definitely prevent something called as intracranial hemorrhage.
Yes, sir.
And Yomika, between
Yes, sir.
spinal and epidural, which one will you prefer, or would you go ahead with spinal epidural combined? And that is one question. Second one is, what are the critical levels of platelets below which you would prefer giving general anesthesia?
Yes, sir. Sir, for in a normal case, I would rather give a combination of spinal plus epidural rather than just spinal alone or epidural alone. And
why would you prefer epidural than spinal?
So because sometimes in cases like preeclampsia, which is already a high risk condition, there might be difficulties during the cesarean section, which might lead to a longer operative time. So epidural would always be better. Which
any other reason granted?
So besides that, spinal anesthesia will somehow lower the blood pressure in itself.
Yes, the drop may be phenomenal, and that may really harm the baby. The baby is already compromised, so that is one reason. So that's why epidural would be a preferred choice, but it takes time. That is one thing. And what are the critical levels of platelets?
So platelet count.
Go ahead.
Platelet count below 80,000, sir. I would prefer general anesthesia.
Okay, fine. 80,000 is okay, but it's 70,000.
I think, sir, excuse me. I think epidural anesthesia. Sir, excuse me.
Yeah. Nimish.
Sir,
Nimish?
yes, sir. Yes, sir. Yeah. Sir, epidural anesthesia, as sir told, is very important when we think about severe PIH and the role of labor anesthesia. And when there's severe PIH, we'll prefer epidural over GA sometime, because as sir told, it lowers the blood pressure. Second, it decreases the pain and decreases the cardiac output. Third, it decreases the catecholamine surge. And fourth, it causes peripheral vasodilatation. And very good it causes increased renal perfusion. So all these things has a benefit of epidural over the spinal or GA.
So in fact, Vyomika, in this patient, we didn't ask that, but even if you're inducing labor, there is a role of putting in the epidural when you're giving a vaginal trial. So, you're not waiting till the last minute and you're rushing. In fact, putting in the epidural earlier, even if you're giving, if she's come in with labor pains and other things, the wonderful benefits of epidural are listed are actually even for within labor, if you're trying for a vaginal birth also, the pain relief is important.
Very helpful.
Reduce the catecholamine surge, improve the circulation. So that's always a good option. Yes,
Good
thank
option.
you, sir, for
Right, that's right.
those points.
Yomika, one more question.
Yes, sir.
Is this patient following up with you since a long?
Yes, sir.
Since how long?
Sir, she's registered with us at 12 weeks, and now she's a PNC mother, and she's been following up with her blood pressure monitoring readings.
So this is a patient of essential hypertension going into preeclampsia, into severe preeclampsia. I would have delivered this patient at 35 weeks itself. What do you want to say on this?
So at 35 weeks, her blood pressure readings on OPD follow-up were somewhere 140/80. So at that point of time, and she had no proteinuria as such.
Okay.
So that's why we had prolonged the pregnancy, and we had planned to deliver at around 37 weeks, which considering a case of chronic hypertension or maybe even a gestational hypertension.
Okay, now you tell me. Yeah, great. That answer is good. Now, when would you deliver a patient of chronic hypertension on treatment under
Sir,
your supervision?
Sir, in a case of chronic hypertension, if your blood pressure monitoring readings are normal on OPD follow-ups and even home BP monitoring, and she's well controlled on medications, I would prolong till 37 weeks of gestation, sir.
38 to 39.6.
Yes, ideally you
Okay.
should.
If
If
they
she's
are
well-
on
yeah.
hypertensives and they are on antihypertensive drugs and they are well controlled, when would you deliver them?
37 to 38 weeks.
No, actually,
Okay,
you should
fine.
say you would not let them cross 39 weeks. 37 completed weeks is the a good cutoff. But the problem of inducing a little too early is also that the section rate automatically goes up. And
Goes up.
the first chance is the best. And what Dr. Gadam said about delivering at 35 weeks, sir, I would like to say that you must be having good neonatologists, because the problem with near-term deliveries is, again, we want to, the other problems of transient tachypnea of the newborn, other problems are also going to be there. So the optimal time to deliver is based on the maternal condition, and the priority here is the mother. Whereas sometimes we do sections for fetal indication, but here the priority is the mom.
We have another 3 minutes to end the session.
Yomika, one more question. If you are planning to deliver this patient at 35 weeks, would you consider giving antenatal corticosteroids?
Yes, sir, definitely.
Why?
Sir, because it has a role in fetal lung maturity, and as per the new guidelines, we still can give corticosteroids in 37 weeks of gestation, sir.
Up to 37. What is the risk of RDS at 37 weeks of gestation? Or
Not
between
exactly
37 and 38 weeks of gestation?
So I'm not exactly aware of the exact figure.
How much?
I'm not exactly aware about the exact figure, sir.
Okay, it is around 2 to 3%.
2 to 3%.
Yeah. So and yet at 37 weeks also it is advocated to prevent that 2% of babies going into RDS.
Yes,
On 37 completed weeks, probably it is not required because the risk is
sir, in fact, I think the RCOG guidelines many years back had put that if you're delivering a patient electively before 39 weeks, you should consider steroids.
Consider giving one dose.
Yeah,
okay.
Any patient.
Dr. Nimesh, you want to say anything?
Yomika, since we are doing the PIH, our discussion should not end with DIC. So can you tell me, in your patient, how will you investigate whether she is going DIC or not? Like old report, old time what was available, and now newer what all tests are available, and how does this newer test help over the old test?
Okay, sir.
Your last question.
Okay, ma'am. Initially, I would send the PTINR and the APTT values of this patient. If it is coming within normal limits, that is okay. If not, if it is slightly deranged, I would go for the complete coagulation profile, which will include the serum fibrinogen levels, D-dimer levels.
Yes, these are all time. Okay.
Yomika, there is nothing like serum fibrinogen. It's plasma fibrinogen.
Plasma fibrinogen.
Yes,
We
sir.
need to talk about serum fibrinogen has been used up.
Yes, sir.
Okay, sir.
And actually, I think we because it's the last minute, we haven't actually spoken about SFLT1 and whether it is tell us it's one of the newer markers which is used.
Yes, ma'am.
Can you tell us a little bit about that?
Yes, ma'am. It's SFLT and PLGF are the two angiogenic factors which we usually use these days for screening of preeclampsia. Not as like a general rule, but these can be the factors which can be tested in the first trimester only with the dual marker test. If the factor value of PLGF is the ratio of PLGF and SLFT is more than 85, it is suggestive of high risk of preeclampsia.
Not just preeclampsia, it's the ones which have the high values are the ones who are more likely to go into HELP syndrome.
Likely to go into
more than just for preeclampsia, it is used as a marker to predict likelihood. It's not used commonly for diagnosis or prediction.
Yes,
of
just a correction.
for prediction of likelihood of HELP syndrome or DIC in those patients.
This is not in the first trimester.
For PGs,
second trimester.
Yes.
Weeks.
Rena, is it the same as AST and ALT?
No, sir.
So,
These are angiogenic factors, and now our private labs have these as tumor markers. I mean,
yeah.
it's like a tumor marker. It's a angiogenic marker, and in fact, Suchitra Pandit, when she was president of Gestosis Society, has actually talked a lot about this, and it is incorporated in one of the things as screening in the Gestosis score. So at PG level, they
But
should read up about these two things. These are
the
the
ratios,
relatively newer things they should know about.
yeah, there. I think the ratio is important. So, but doctor, you didn't answer about the newer DIC investigation which are available nowadays, and how this will help you in a PIH case. You told about plasma fibrinogen, PT, APTT. What are newer thing available?
Yomika, you around?
Yomika,
Yes, ma'am.
Yomika, doctor.
Yes, I am hearing.
Yes. So have you heard about TEG and rotational thromboelastography? Thromboelastograph.
Yes, so elastography I've heard about, but I've not read
Yeah,
about it.
TEG. It is available in all the corporate hospitals. TEG and but how they help us? Rotational thromboelastography.
Sir,
It will
see,
tell you
one
what
of it-
product to be given, what product you can give to your patients who are in DIC. They help you. This TEG. So you should know in exam, because some examiner from corporate hospital will come. They'll ask you this TEG and Rota. So just to
this thromboelastography costs around 10,000 rupees.
10,000
for the
rupees.
test.
Yes, ma'am. Yes,
Yeah,
ma'am. Yes,
so
ma'am.
if
But it's
all patients can't afford it, but
yes,
it
ma'am.
comes as a graph, and it will help based on what you find, that which are the factors you need to ask for when you ask for components.
But
So,
Rina, you get the report within 15-20 minutes. That's the basic advantage.
Yes, you get in 15 minutes. Yes, sir. Yes, sir.
That's
You
the
get
basic.
report immediately, and you can give whatever product you want to give to the patient, and they'll help us. Yes, sir.
But that's mainly important for factor deficiencies more than anything else, isn't it,
Yes,
Dr.
sir.
Saroge?
Yeah, it's basically for DIC to rule out
Right,
what
sir. It's for DIC because in
Yeah.
not just factor deficiencies, even in a case where you are having DIC, patient is not responding to your standard therapy, they say do this TEG.
The advantage is if you ask for fibrinogen or any other test which are related to DIC, it takes about 4 to 6 hours. As
Yes,
sir
sir.
rightly said, this TG is available in 15 minutes and
15
it
minutes.
exactly tells you what blood
What
component
to be given.
But this
Yes.
is in established DIC rather than predicting DIC.
Yes, sir.
Correct.
Going
Yeah.
again. Yes, sir.
It's for the treatment. And usually we do it with a hematologist, helping in the test. I
So
think
most of the
Leelavati
bigger
Hospital, Nanavati Hospital.
Leelavati, yes.
Most of the
Leelavati,
bigger
yes.
hospitals
Yeah.
where transplant programs are there, this
Yes.
machine is available and it's very simple, because the technician is there present, he can give the reports in 15 minutes.
Yeah.
So
And
we
it's
now,
odd hours.
yeah, we can stop here.
Yes.
One closing remark from all of you all.
I think it was a good presentation. I think we should pass her. And
Vidya, you have done a wonderful job.
Yeah, but the
Vidya, you have
important
done a
practical
wonderful job.
points, they should
Thank
not
you.
forget.
She was doing almost everything of PIH. She was answering ma'am's all
Okay.
questions.
Yeah.
No,
Yomika,
she's
when are you
she's
appearing for your MD exams?
Yes. So I
Thank
think
you,
Yomika, you did
Vidya.
very well.
Thank you
Yeah.
to AFG for this wonderful interaction.
So before closing the case one, I thank Dr. Reena Vani. Thank you for accepting our invite and actually giving major potential inputs to the student. Thank you,
so
Dr.
much.
Sarogi. Thank you, Dr. Gadam, as always, and Dr. Karthikeyan. I think we close this session. And now we have Dr. Yomika. Thank you so much. You did
Thank
really
you so much,
well.
ma'am. Thank you so much.
Yeah.
Thank
Yeah.
you, everyone,
And,
for giving me the important insights for the
Yeah.
case. Thank
Yeah.
you so much.
Now,
Yomika,
you are getting
Yomika,
gold medal.
what I will suggest is, Yomika, you should convey it to all your resident doctors around you.
Yes, sir.
We have these RAN symposium every month, and this
Right,
is
sir.
going on since 2002, 2003.
Yes, sir.
Yes.
You all should attend these lectures properly, and it's worth attending.
Right, sir. Absolutely.
Yes.
I totally agree with it.
Yeah. Now we go on to the second session. That is the specimen. So in the exams, we have specimen. So we have Dr. Jignesh who will actually enlighten us about how to go about when a specimen is there. Dr. Jignesh, are you around?
Unmute yourself.
Yeah, good morning, Dr. Vidya.
Yeah. So Dr. Jignesh will take over the specimen of rupture uterus. Dr. Jignesh?
Yeah, just 2 minutes. Hello, you can hear me?
Yeah.
Yeah, Dr. Jignesh.
Yeah, okay.
You have exactly 20 minutes, sir.
Yeah, okay, fine. That's very good of you. Thank you. Good morning, everyone. Today, what we're going to discuss is a specimen. And in that case, it's a specimen of obstetric uterus, especially rupture uterus. To all the students, as we go ahead, just showing you a photo of a rupture uterus. It's a specimen. And I would like all of you in the next few seconds in your mind, how would you describe this specimen in your exam if you have come across, okay? That is a very important thing which you have to just think about it before we go ahead with the discussion. Just see the specimen. What is it a specimen of? How is it? What are the features which you can see in the specimen? Okay. Why do you call it a uterus? Why do you call it a postpartum uterus? Obstetric, and what else you can see into it. So whenever we get a specimen of the uterus, it's very essential that we describe the specimen. Okay. And once we describe the specimen, we confirm it's a specimen of which organ. In gynec and obs, what we deal with is uterus, is the tubes, ovary, the adnex. Okay, these are the principal area and the cervix. So this is an obstetric uterus. Why do we call it obstetric uterus? Because what we are seeing here is that it's a pear-shaped organ. It's enlarged, which is a uterus. Okay, the adnexa is not seen. Secondly, we see the peritoneal folds over it, which are transverse, oblique, vertical, which is called as the Duncan and Matthews folds, which tells you that it's a obstetric uterus. You cannot see the fetus inside, okay? So it's a postpartum specimen. If you look close to it, then we find that's almost the whole of the uterus is there, okay, right till the cervix. The lower segment completely is there. And you tend to find that there is a vertical tear obliquely going up on the anterior wall of the uterus, which is extending right from the lower segment into the body of the uterus. So it's a specimen of the uterus which is measuring roughly 20 centimeters by 14 centimeters by 6 centimeters in size, with the peritoneal folds seen over it, which suggests it's an obstetric postpartum specimen. And there is a tear which is seen on the anterior aspect obliquely going from the lower segment into the upper segment, which suggests it's a specimen of ruptured uterus. Having said this, we also mention about whether the adnexa is seen or not. The adnexa in this particular case, we cannot see, we only see the uterus. The important thing is to find out whether if you see a rupture, any additional ruptures are there anywhere in the specimen, in any other specimen, any hematomas are there along the line. If the adnexa has been removed, is the adnexa normal in appearance on one side or both the sides have been removed or not removed? Besides this, we also require to see if there's adnexa, if there is a hematoma, is there, or any other abnormality can be seen, which suggests that why the adnexa has been removed. So all these factors we require to know. And when you're mentioning in your exam. The other thing is in the uterus, we also require to say has this particular specimen we mentioned, that is a total uterus which is there, right? So that is a total obstetric hysterectomy has been performed on this patient. Sometimes you may find only a part of the uterus is there, where the lower segment, upper part is there, the lower part is missing in the cervix. So that means it's a subtotal hysterectomy has been performed. In case if the specimen is there with the adnexa, and along with that there is a parametrium is seen, and you find the whole of the vagina is there, then it's likely to be a postmortem specimen. So this is another important factor one requires to. Now, the next important thing is that when we describe the specimen in the exams, as I mentioned earlier, we describe the whole specimen, we give our diagnosis that this is a specimen of a total obstetric hysterectomy has been performed in a case of a rupture uterus, which involves the lower segment vertically going into the upper segment. Having said this, then we next go on to either you may be stopped by the examiner subsequently to question you further directly, or in case if you are not stopped, then you can continue your running commentary about the specimen. that a total obstetric hysterectomy has been performed in this particular case for a rupture uterus, which is involving from the lower segment going up into the upper segment. And in this particular case, most probably the patient must have been in the late second stage of labor. At that particular time, suddenly she must have experienced an excruciating pain in the lower abdomen and in the vagina, and she must have collapsed with tachycardia and hypotension. Sudden gush of bleeding per vagina is there. You tend to find that the pollex greater is empty suddenly. The fetal parts are superficially felt, and the fetal heart rate is abnormalities, irregular going towards severe fetal bradycardia. For vaginal examination, the cervix loose hanging, the fetal presenting part is not felt. There may be hematuria may be felt. I would like to immediately inform the OT, the anesthetist, and the neonatologist, and take the consent from the patient and the relatives for shifting the patient to OT and doing exploratory laparotomy, and take a consent for SOS obstetric hysterectomy, which could be subtotal or total, may require to do a salpingo-oophorectomy or interiliac artery ligation also along with that. At the same time, 2 IV lines are put into the patient on both the sides. Okay, if the blood has previously not been sent for grouping and cross-matching, then we'd like to send the blood for grouping and cross-matching for PCV, for frozen plasma, and for platelet concentrates. So availability of this blood components also has to be inquired with the blood bank immediately. Besides this, basic blood tests in the form of CBC, TT, and APTT should be sent at that particular time. Police catheterization is done, consent is already done, patient is shifted to the OT, and through a midline vertical incision without wasting much time under general anesthesia or obstetric hysterectomy has been performed. So this is how exactly you would be presenting your specimen in case if you're not stopped. Once you're finished with this, then you're bound to be asked various questions. And some of the questions that you're going to be asked is, Doctor, what do you think is the common cause of such a vertical tear which is going into the upper uterine segment from the lower segment? So what are the common causes? One is a difficult forceps application might have been done. Then if there is an internal polalic version may have been attempted, or there is a breech extraction has been done, or in some cases which we do not do, but the maybe a duration incision might have been given and which may have extended up into the lower segment and into the body of the uterus. So that is another important thing that has got to be kept in the mind. Now, the other questions which comes to that, suppose there's a different specimen is there. Instead of this lowest, you may find a transverse lower segment rupture is there. Okay. Whenever the transverse lower segment rupture which is there, then in that case, what are the causes for that? Okay. So most of the times it may be in a case of when the patient is undergoing VBAC, or even before VBAC also the patient comes into labor, with a previous cesarean section or a previous hysterectomy has been performed. Then also that could be a transverse lower segment section rupture with an oblique extension, maybe upwards or downwards could be seen. In those patients who there undergoing labor and there's an obstructed labor, there's CPD is there, or there's a fetal congenital anomaly which is compressing into the lower uterine segment and the pelvis is there. There is overzealous use of oxytocin. External version has been performed. And in a postpartum patient delayed, one may also see rupture uterus because of uterine incisional scar necrosis and dehiscence. Upper segment rupture, if you do find that, now then in that case, clinically, how does it mimic upper uterine segment rupture? Upper uterine segment ruptures, you will tend to find that especially with a posterior rupture, the patient clinically, if you see, then maybe have incoordinate uterine activity will be there, okay? And it will be more mimicking like symptoms and signs of abruptio placenta. Now, what are the different causes? In your mind, when you're going to go for this exams, you have to discuss in your mind exactly if there is certain specimen is there, then what are going to be the causes for this particular one? So suppose you get a rupture uterus of the upper segment. So what are the common causes? You should be able to enumerate. If there's a past history of uterine instrumentation with known or unrecognized injuries there, previous myomectomy or metroplasty has been performed, previous history of classical cesarean section. In the present pregnancy right now, the patient may have blunt or penetrating injury. If you're performing external version and it's been very roughly done, only then you may have a rupture uterus. Also, in the past history, if there is a deep corneal ectopic pregnancy for which there is a deep corneal resection has been done of the interstitial oviduct, that may also give way in the previous pregnancy. Pregnancy in the undeveloped rudimentary horn may also lead to a rupture uterus. During a difficult MRP postpartum, after delivery of the baby, or placenta acreta spectrum also, you can have a rupture uterus in the upper segment also. Circulation of entrapped retroverted uterus could be there. So these are some of the causes which are there. You should be knowing that which are the common causes, and you should be able to enlighten at that time in your exam. Sometimes there may be a specimen where there may be a tube and ovary unilateral or bilateral also may have been removed. So in those cases, when is it likely to be done? When there is a broad ligament hematoma is there, there could be cancer cervix for which elective LSCS and a uterine hysterectomy is being performed, something is there, or trophoblastic disease. Total hysterectomy is done, as I already previously mentioned, when there is a cervical tear which is extending into the upper segment, okay, placenta previa and accreta syndrome. There may be a scar, ischemic or cervical ectopic pregnancy, then also we do perform total hysterectomy. Colporexis also, which is where may require a total hysterectomy, and a trophoblastic disease. Also, it is a very important question to understand what is the difference between a rupture uterus and a scar dehiscence, especially in the patient who is undergoing VBAC. When there's a scar dehiscence is going to be there, there is no communication between the peritoneal cavity and the uterine cavity. The underlying, the utero-vesical fold of peritoneum is intact. In a rupture uterus, there's a total disruption of the uterine muscles, which extends to and involve the uterine serosa. Okay, and in certain cases, there may be extension to the urinary bladder, or the broad ligament hematomas may also be there. Also, one of the important signs, especially in patients who are undergoing VBAC, it is to remember that the first sign of scar dehiscence or scar rupture is not going to be maternal tachycardia or hypertension or scar tenderness. The first sign is going to be form of fetal heart rate irregularity, okay, of any kind, because it's there whenever the process of disruption of the myometrial fibers tends to occur, there's a reflex neuronal decrease in the uterine blood flow, and subsequent placental perfusion also tends to reduce, leading to fetal irregular of different forms. So I think we have in short discussed about how this thing is there, of specimen of rupture uterus. And I think maybe next time we do a specimen, we will have one of the students to describe the specimen, okay, electively, so that it can become interactive session. Fine. Thank you.
Okay, thank you, Dr. Jignesh. That was a nice description for the students to understand how to go with the specimen when it is given to them. So now we begin with our third session. We have with us Dr. Gayatri Masood. She is a resident of Nauroji Vadia Hospital. And for this session, we have Dr. Trupti Nadkarni. She is a professor and she's also an examiner for the PG students. And we have, along with her, we have Dr. Motwani, Dr. Rajkumar Shah, and Dr. Nimish. Dr. Gayatri, can you share your slides, please? Am I audible?
Yes.
Yeah. So, Dr. Gayatri, are you ready with your slides?
Should I start now?
Yeah, please share your slides.
So, ma'am, good
Share
morning
your
to all the
slides, better. Share your slides.
We can't see your slides, Gayatri.
Welcome, Dr. Trupti.
Yeah.
Any other input till then from the experts regarding the specimen? For the students, anything more information was needed? I think Dr. Jignesh did a good job. He actually gave all the insights of how a specimen should be described. Any other inputs?
See, it's okay if it was a rupture uterus. I'll put it this way. If it's a case of hysterectomy specimen which is being given, you should be knowing about three things. One is whether it is an antemortem specimen or a postmortem specimen. Second, whether it is anterior, which is the anterior surface, which is the posterior surface. And third should be what was the indication of doing that hysterectomy.
Yes.
Fourth, was it a vaginal specimen or an abdominal specimen? Four things you should know about the hysterectomy specimen which is being given to a student.
Okay, sir. Thank you. Thank you. Now we begin with Dr. Gayatri. Dr. Gayatri, all yours.
Good morning to all respected dignitaries. I am Dr. Gayatri Masood, third year resident from St. James Medical College, and I am going to be presenting a case on an antepartum hemorrhage.
Dr. Gayatri?
Yes, just a sec.
Yeah.
Technical glitches, I think, get the heart rate up same as they are in the exam. So,
I totally agree. And even for the convenience.
I'm not able to share.
You are not able to share. Can you do one thing? Dr. Nimish, are you around?
Can you send the presentation to ClearNet? They'll be able to do it probably.
Yeah. Actually, wait, I'll try to do. Just hold on.
That should always be done actually.
Yeah,
Always
yeah.
send the presentation to
backup.
ClearNet from next time on.
No, they had sent it to me, sir. I'll just try to.
Acha. Okay.
Yes, ma'am.
1 second. Huh? Yeah, I think I will share the screen. Only thing is, 1 second. Dr. Gayatri?
Yes, ma'am.
I think I will share it. And 1 second, I'll share. You stop sharing, beta. Just stop sharing.
No.
Yeah, can you all see now?
Hello?
Yeah.
Perfect.
Can you see now?
Perfect.
Yes.
Yeah, okay. Yeah, continue, Dr. Gayatri. I will.
Ma'am, can you hear me?
Yeah, we can hear you.
Ma'am, so my patient name is Mrs. Sandhya Pawar. She is 28-year-old
Yeah.
This 28-year-old gravida to para-1 living one, previous normal delivery, married since 4 years, a homemaker by occupation, resident of Parel. She's 34 plus 5 weeks of gestation. She came to the casualty with complaints of bleeding bleeding per vaginum since 2 hours, pain in abdomen since 2 hours, and complaints of decreased fetal movement since half an hour. She had no complaints of leaking per vaginum, trauma, history of fall, coitus, fever, headache, blurring of vision, or loss of consciousness. Patient is also a known case of gestational hypertension, diagnosed at 30 weeks of gestation and is currently on rapid 100 mg BD. Ma'am, next slide.
Yeah, go ahead.
So, ma'am, the patient was asymptomatic 2 hours back and she suddenly had an episode of a vaginal bleeding, which was dark red in color. So, one pad associated with the passage of clots, associated with severe abdominal pain, which was sudden in onset, continuous in nature, severe in intensity, associated with tightness of abdomen, and associated with decreased fetal movement since 2 hours. Ma'am, her menstrual history. Menarche was attained at 13 years of age. She had a regular menstrual cycles of 28 to 30 days cycle lasting for 3 to 4 days with soakage of 2 to 3 pads per day with moderate flow and no passage of clots and dysmenorrhea.
What comes to your mind? Hold, my dear. What comes to your mind looking at this history? What comes to your mind looking at this history? Can you hear me?
Yes, Manurika.
Can you hear Gayatri?
I think this Wi-Fi problem. I think the image is still.
Vyomika, can
Yes, ma'am.
is
Yes,
there a
ma'am. Actually,
Wi-Fi
she's
problem?
here. She'll be
Okay.
using. Yes.
Yeah, yes, you can.
Sir, you were asking something. Hello, sir.
Yeah, Vyomika, what I'm asking is what comes to your mind? You have a patient for the first two slides which you showed me, or
Yes,
showed
yes.
all of us. What comes to your mind?
Sir, patient has a history of bleeding PV. So she has some kind of antepartum hemorrhage going on, which is associated with pain in abdomen, and patient is also a known case of gestational hypertension. So I am suspecting, sir, abruption.
Okay, go ahead.
Patient might be an abruption.
Okay.
Yes. Sir, next, obstetric history, sir. She has a previous living issue, female baby, 3 years of age, delivered vaginally. Birth weight at delivery was 2.8 kg, cried immediately after birth. She had no history of associated antenatal or postnatal complications during that delivery. This is her present pregnancy, conceived spontaneously. She has registered in the antenatal OPD at 10 weeks of gestation, has taken folic acid. First trimester screening has been done, which is normal. She's compliant to hematinics and calcium. Anomaly scan was normal. USG color Doppler was done at 30 weeks of gestation, which shows adequate growth and flows were normal. On routine ANC follow at 30 weeks of gestation, patient's blood pressure was found to be elevated, 140, 100, 150, 90, sorry. And then the patient was started on labetalol 100 mg BD and was advised home BP monitoring. Along with routine blood investigation, urine protein creatinine ratio was done, which was 0.18, and patient was regularly followed up in ANC OPD.
So
This is your
Gayatri, are
Yes.
there any predictive factors in the first second trimester which can tell you a possibility of development of antepartum hemorrhage?
Yes, sir. She was diagnosed with gestational hypertension at 30 weeks. So that is a
No,
predisposing.
Before that.
Sir, before that there were no previous bleeding episodes. So, sir, nothing suggestive of abruption.
Besides the bleeding episodes, when you're doing a screening of a patient, so when you're doing a screening of a patient, you do a dual marker, right?
Yes, yes.
And earlier days also we used to do something called as quadruple marker.
Yes.
So what are the factors which are tested in quadruple marker?
Sir, quadruple markers, there are 4 factors which are tested, which is alpha fetoprotein, inhibin A, beta HCG, and unconjugated estradiol. In dual marker test, we test for beta HCG and PAPE levels.
Yeah. So the quadruple marker,
low
low
PAPE levels are suggestive of hemorrhage in the 3rd trimester. Sorry. For preeclampsia, which might be a predisposing factor for placental abruption, sir.
Yeah. So
okay, guys, how many?
Inhibin A and yeah, Mona, you're saying something?
Hey, you finish it. I'll come after that.
Yeah. So 3 of these parameters of quadruple marker, if they are raised, then there's an 8-fold chance of developing antepartum hemorrhage. Unfortunately, these days we are not doing quadruple marker because dual marker has replaced everything as such. But this is something which is worth knowing.
Yes.
Okay, go ahead.
In how many cases of abruptio is hypertension responsible?
Sorry, sir?
In how many percentage of patients is hypertension responsible in cases of abruptio?
Sir, I think it's 30 to 35%. I'm not exactly
Yeah,
sure.
30 to 40%. Most of them may have normal blood pressure, normal findings. Absolutely.
So, Gayatri, what are the other risk factors apart from hypertension? What are the other risk factors for abruption, and does your patient have any of them? Could you tell?
Yes, ma'am. Past history of abruption. If the patient has a past history of abruption in the previous pregnancy, it increases the relative risk by about 10 times. Then, if the maternal age is more, if there are any hypertensive disorders of the pregnancy, if there is any history of trauma, any history of trauma to the abdomen, any history of thrombophilias, if there is a sudden decompression in cases of twins or in polyhydramnios, if there is a uterine anomaly, abnormal placentation, multiple pregnancies, they all might be risk factors for placental abruption.
Any
Including
personal
heavy-
habits?
Sorry, you were saying something. Sorry.
Cigarette smoking, yes, ma'am. Cigarette smoking.
Drug misuse,
Cocaine.
drug abuse.
Cocaine.
Commonly seen nowadays, cocaine, amphetamines.
Cocaine.
And IVF pregnancy, so remember?
IVF.
Yeah.
Assisted reproductive
Especially if it's a donor egg, then more possibilities, you know?
Yes.
Okay. So your patient has hypertension. All the other risk factors were not present in your case, right? Okay. Go ahead.
Ma'am, in past history, the patient has no history of previous bleeding episodes in present or past pregnancy, diabetes mellitus, trauma, history of smoking, history of any drug intake, history of tuberculosis, epilepsy, coagulation disorders. She has no past surgical history, any history of allergy or history of any blood transfusion. There is no significant family history of hypertension, diabetes, or bleeding disorders. Then we go ahead with the examination, ma'am. Patient was conscious, oriented to time, place, person. Patient was febrile. Pallor was present, ma'am. Pulse rate was 112 beats per minute. Blood pressure was 160 by 100 mm of mercury. SpO2 was 99% on room air. CVS examination, both heart sounds were present. RS examination, air entry was bilaterally equal. Bipedal edema was present. There were no premonitory signs and symptoms. Urine albumin was traced. In per abdominal examination, it was corresponding to 34 to 36 week size uterus. FHS was localized, which was 140 to 150 beats per minute. Fetal parts were difficult to palpate, and uterus was tonically contracted. On per speculum examination, cervix, vagina appeared healthy. There was no visible any external trauma to the cervix or vagina. Bleeding associated with clots were present. On vaginal examination, cervix was soft, os was closed, poorly effaced, and bleeding was present. Then we did her investigations. CBC, complete blood count revealed hemoglobin levels of 8.5.
Just interrupting you, when you have such a patient, now on basis of your examination, what is pointing towards abruption, and how have you ruled out other causes of antepartum hemorrhage?
Yes, ma'am. First of all, ma'am,
And if it is an abruption, what degree do you think it is? How severe the abruption do you think this is?
Abruption, actually, there are 4 grades of abruption. There is different classifications. There is one page classification and one Shaw classification. In page classification, there are 4 grades: 0, 1, 2, 3. In 0 grade, there is no external visible hemorrhage. After delivery, only placental examination, we can see if there is any clot or something is present. In grade 1, ma'am, there is a slight external bleeding is seen. Uterus is irritable, but it is not tender, ma'am, and fetal heart rate is good. In type 2, there might be some distress, ma'am, and external bleeding can be present. Shock is usually not seen, and uterine tenderness is marked. And in grade 3, ma'am, there is maternal shock and presence of intrauterine fetal device. This is the PACE classification, and then the Shares classification is based on the amount of the hemorrhage, which is if it is less than 150 ml, that is grade 1. 150 to 500 ml is grade 2, and more than 500 ml is grade 3. So
this patient, do you think would require an emergency management, or would you admit her and wait, because all these investigations will take at least a couple of hours to come?
Yes, ma'am. Ma'am, first of all, I would like to see for the fetal heart rate. fetal heart rate, if the fetal heart rate is good, and now the patient is also having tachycardia, she is having high blood pressure, uterus is tonically contracted. So I would like to deliver her as soon as possible.
How would you deliver her?
Ma'am, delivery can be based on depending if the fetal heart rate is good and if the patient is vitally or hemodynamically stable, ma'am, we can do an amnio. If the biceps is favorable, we can do an amniotomy for her. And if after amniotomy, the placental abruption can be reduced to some extent, then we can expedite the labor by giving oxytocin or something.
Let's come to this patient better. Let's come to this patient. We have asked you this. What we can do and others is hypothetical. What about your case right now?
Your case, you said os is closed, right? Your cervix,
Yes,
you said
ma'am.
vaginal
Yes, I would like
findings.
to
You
do an
said
emergency lower segment cesarean section for her.
That's what you want
After
to do.
confirming,
Good.
after confirming the blood and blood products availability, because we might require to transfuse her.
What complications do you expect in her? You got a
Sir,
tonically contracted uterus with abruptio.
yes.
And it's something like your
Disseminated patient might land up in DIC, sir. So I would like to keep all the blood.
shock. Let's go to DIC a little later. Suppose she goes into shock. She's in shock. How is the shock different from a shock of PPH? Suppose she comes in shock to you. You pain patient is pale, pulse is 140, 150, systolic is 90. How will you say the shock is different from the shock you see in PPH? What is the shock difference in abruptios compared to non-abruptios? Is it in proportion to the amount of blood loss, out of proportion to the amount of blood loss?
Sir, it is out of proportion.
That's
in
the
amount with the blood
typicality of
loss. That is
concealed
the
hemorrhages. Yeah, that's the peculiarity. She may be white as ever, and you find there's hardly any bleeding outside.
Yes.
Would you
So now
do any bedside tests before taking her up for a?
Yes, ma'am. BTCT, I would bleeding time and clotting time. I would like to do. If the investigation.
Can you tell us how these tests are done?
Ma'am, bleeding time. We would like to.
And what are the normal values of these tests?
Ma'am, for bleeding time, the normal values is 2 to 7 minutes, and for clotting time, it's 4 to 11 minutes, ma'am.
Okay. And what is this telling you? Why are we doing these tests?
Ma'am, if there is any coagulation abnormalities which is happening or the patient is going in DIC, and I would like to know that. That's why immediately bleeding and clotting time can give me the results in short amount of time.
No, what is the significance of bleeding time? What is the significance of clotting time? What information do you get by doing bleeding time, and what information do you get by doing clotting time? How do we perform bleeding time test?
So first, I like to prick the patient and then prick the patient, and then if the blood is coming out, then I'll see at how much amount of time the blood is stopping. That would be my bleeding time, and clotting time would be the fibrin.
So what sir has asked is, what function is the bleeding time telling you? Function of which blood component is the bleeding time giving you information about? And what is the clotting time giving you information about? So these bedside tests are done because in a case of abruption, especially maybe a severe abruption, you may not have time for your entire coagulation profile to come, but you need to have some idea of her coagulation status when you're taking her up for a cesarean section.
Why the blood stops immediately within 2 to 5 minutes?
What helps it coagulate? What helps it stop bleeding?
Platelets.
Platelets.
So bleeding time is giving you information about the platelet function. And what is clotting time giving you information about?
Extrinsic coagulation pathway.
Other factors, right?
Clotting factors.
Yes. And an extension of this is what is called as clot retraction. Yes. And then there is what is called clot dissolution. So all this gives you a bedside view of what exactly is the coagulation rather than waiting for the lab reports to come.
Yes, ma'am.
How sensitive are they?
Sorry, sir.
How sensitive are these tests? How much can you depend on them? And how many of you people still do it in your hospitals?
Sir, we do it. Sir, if the investigation is taking time, then we do BTCT and then we take up the patient for us.
See, the sensitivity of bleeding time is about 30 to 60%, and clotting time is just about 30%. So they are not going to pick up all those cases of yours. So it's a good help, Anu, but you can't depend on them always. So your blood has to go for coagulation studies. So what coagulation studies would you order?
Sir, I would like to do a platelet count. Then I would like to do a fibrinogen, plasma fibrinogen test. Then I would like to see for the serum plasma fibrinogen, then fibrin D-dimer, fibrin degradation APTT test. I would like to do.
And what about PT and APTT?
Yes.
Yes, sir. PTINR, yes. PTINR and APTT, yes.
So
what
all
happens to these?
Sorry.
Yeah,
Yeah, go ahead, Trupti. Go ahead.
No. What happens to these coagulation tests normally in pregnancy? Values, interpretation in pregnancy will be a little different from interpretation in non-pregnant patients.
Ma'am, they are prolonged, ma'am.
They are prolonged. So, if between all these tests, which would be a more sensitive test to pick up if you look at fibrinogen and D-dimer, which would be more effective in picking up DIC?
Abruptio, yeah.
Because normally the fibrinogen values, the D-dimer values are increased, after 20 weeks, even in normal pregnancy, they go up to 2 to 3 times. So fibrinogen, lower fibrinogen values less than 200 are more sensitive as a
marker
indicator for DIC.
So here is the point where we were discussing in the previous case, the role of thromboelastography. It's not elastography, please. It's thromboelastography, where a blood sample is drawn and given to the lab for assessment. And in 15 minutes flat, you get the results which tell you, which are the components to be used. It will not tell you what exactly it means as such, but it will tell you what blood components to be used just in case there's a DIC. So use of plasma, use of platelets and other things, or use of fibrinogen, cryoprecipitated, all that the TEG will suggest. And therefore, that's a handy test, but of course, it's expensive and not available in major of the hospitals. So therefore, we resort to whatever test you just mentioned. Go ahead.
Go ahead, Gayatri, with your proof.
So you said coagulopathy is one complication. What are the complications can you have in abruptio other than this? Have you lost her?
You're mute, Gayatri. Just unmute yourself. Yeah.
Gayatri?
Yes.
Hello?
Yes.
Gayatri, what are the complications can you other see in abruptio? You've said DIC. And
Sir, there are maternal and fetal complications. In maternal complications, the patient can land up in a hemorrhagic shock. The patient can have postpartum hemorrhage. There can be disseminated intravascular coagulation. There can be oliguria, ma'am. Initially, it might be acute tubular necrosis, which may later progress to chronic cortical necrosis. Then there might be a purpural sepsis, ma'am. Then high chances of recurrence of abruption in next pregnancy. Then in fetal complications, ma'am, there might be prematurity. There can be asphyxia.
Go ahead.
For gestational age babies can be.
Go ahead.
Hello?
Yeah, go ahead.
Yeah, go ahead. Go ahead with your presentation.
Acha, go ahead. Okay. Then diagnosis, ma'am. So my provisional diagnosis is she is 28-year-old, gravida to para 1 living 1, previous normal delivery, 34 plus 5 weeks of gestation with antepartum hemorrhage, which is secondary to placental abruption.
mention about the lie of the baby. You heard Reena discussing in the previous case. So it's important, If it's an abnormal lie, you know for sure that this she will definitely land up with a C-section. Mentally, you'll be prepared as to how to deliver at C-section. So all these are important things which have to be mentioned in the provisional diagnosis.
Sir, actually, in per abdomen examination, we could not define the presentation.
That's fine. That's fine. Yes.
The diagnosis.
Okay. So what was done?
So patient was immediately taken up for emergency lower segment cesarean section, sir. And blood products were transfused, sir. Her
Any
hemoglobin
role
was
of ultrasound in your case? Any role of doing an emergency? If you have provision to do an ultrasound in the labor ward, is there any role?
Yes, ma'am. I would like to see if the placenta is low lying, if it is also low lying. Then I can see. Then if the presentation I cannot ascertain by the per abdominal examination, then by scan at least I can see it is a breach or a kefal.
Yes. So since you said you're not able to ascertain on your clinical examination, ultrasound could help you do that. It would rule out your other causes of antepartum. It would rule out placenta previa. And can you see a clot? Can you see retroplacental bleeding on ultrasound?
Yes, ma'am.
Will you be able to see in an acute case?
Always.
No, ma'am, not always.
So you might not always be able to see in an acute case because the bleeding is almost isoechoic. So it is not something which can give you a definitive diagnosis. So an abruption diagnosis is almost always clinical and which is then confirmed by, post-delivery.
So a word of caution here is that don't spend time doing a sonography, sending the patient to the sonography department, waiting for the reports and other things. That is a precious loss of time. In fact, the literature also mentions very clearly that there is only a 25% possibility of diagnosing accidental hemorrhage on sonography, and it does not help you in any which way. So don't lose precious time in doing a sonography. Of course, if it's available in the labor room where you can do it yourself, it's a different thing altogether. But besides that, sending the patient to a sonography department, waiting for the reports to come is just a waste of precious time.
Sir, I just add to you, sir. We have, I'll just add to the sir message to all the residents. Sir, we have missed 2-3 babies like this only. Abruption is a clinical diagnosis. Ultrasound will never help you. If you have an ultrasound showing placenta previa or anything, localization there, don't do ultrasound. 75% ultrasound will miss EPH. Abruption. And if you get abruption clinically, don't send. So residents should send patient ultrasound. Their patient wait because no one was there to do ultrasound, and we came with the IUDs. And then patient going DIC and AKI. So I think the abruption is a LR diagnosis, and whatever you should decide by NST and take the patient section or induce the patient.
Okay, Gayatri, what happened? Your patient went for a sonography, she got lost, and you got an IUFD. What do? This patient unfortunately got
so now
an
you have an abruption with an IUFD.
Yeah, now how will you manage this patient?
Sir, after getting all the investigations, DIC profile, complete blood count, liver function, renal function test, then I would like to do, if the Bishop's is favorable, then I may consider amniotomy for her, followed
if
by...
If the Bishop's is favorable, then IUFD, would you go in for a cesarean section directly if the Bishop's...
I would... No, ma'am. Oh, no, ma'am.
Which conditions of IUFD would you do a cesarean?
Ma'am, if the bleeding is disproportionate, if the patient is going in shock, if the patient is not vitally stable, then I might consider for a emergency LACS.
Doctor, in this case of abruption, we always think of mother first. Anywhere, it comes with the live baby or without live baby. The mother is the first thing. Baby is always there. So now baby is not there. Now baby is not there. Okay, now only mother is there. So now what are the things which will tell you to give a trial of labor and not section? So now we are not going to do section. So which patient you will give, induce the patient, and which patient of IUD you will do direct section. No trial.
So yes, sir. So there are 2 criteria. If the patient is vitally stable, if all her labs, if her blood count and her DIC profile is normal, then we might consider an induction of labor for her.
Urine output also. Urine output also.
Gayatri, again, it needs to be emphasized that abruption is one case where you do not wait for all the lab reports. You have an IUFD which has been caused by an abruption. it is definitely a severe abruption. You need to start expediting her delivery and start resuscitating her with the adequate blood components immediately, because you cannot wait for another 1 or 2 hours to get the labs and then start. So it all has to go simultaneously. So tell me, when it comes to induction, what will you do? So what are the steps? How will you go about inducing the patient?
Sir, ma'am, first I would like to see whether her DIC profile is, if the DIC profile is not, if the patient is vitally stable, ma'am, then only we can consider induction of the.
Okay, so what will you do? What are the steps in induction?
Ma'am, first I would like to transfuse her with blood and blood products. Then I might consider induction of labor depending on the bishops, ma'am. If I can put
She's 1.5 centimeters. What will you do?
1.5 centimeter, ma'am, then I might consider induction of labor with Foley's.
No.
So what is advised normally in cases of abruption? The one thing that you should do
Yes.
to,
Yes.
reduce the blood loss, to accelerate her,
Even with
labor.
1.5 centimeter dilatation. Yes, that's true.
Amniotomy is a better thing, because then the placental abruption, whatever it is, it gets reduced, ma'am. After doing an
amniotomy is advised. You're looking at late, rupture of membranes normally when you're looking at a normal induction of labor, but this is one condition where an early rupture of membrane, that will not only give you your diagnosis or confirm your diagnosis, it will also reduce the level of abruption and it will augment labor. Because patients in abruption, because of the tonically contracted, because of they progress faster than the regular patients in labor. So these are patients where you can do an amniotomy and start an oxytocin drip, and most of them will progress in labor.
What is the timeline you have to deliver them? Anything is there in literature? Is there any timeline drawn around that I can't wait for so many hours? Beyond that, I have to do a C-section? There is no timeline.
As long as the patient is stable,
No
not
time.
actively bleeding.
Normally, but an average thing over the years, we've heard it is about 6 hours. If it doesn't go right in 6 hours, be safe, get it and get the baby out. We have no evidences given. These are all anecdotal. People say, but over the years, even as a student, I've only heard this, that it has been around 6 hours. But as she said, labor goes like magic. It really goes very quickly. What is covalent uterus? Are you worried about it?
Yes, ma'am. Covalent uterus, ma'am, it is an extravasation of the blood into the uterine muscles in association with the severe form of concealed placental abruption. Actually, sir, it is. I am not concerned. Concerned with the covalent uterus, ma'am, because it is not. It resolves after the delivery, ma'am.
No. So
not all covalent uterus are
yes.
hypotonic. They're not all of them. They all look covalent, but they're well contracted at most of the times. Now, suppose this patient is in DIC. You see that patient is bleeding, your blood is not clotting. How do you mobilize your blood bank? What do you use? Fibrinogen 100.
I'd like to first transfuse her with FFP, sir.
How many? How much does 1 unit of FFP increase your fibrinogen by? How many 4 units increase how much by? What is your target? A 50 kg lady or a 60 kg lady? 4 units, 50 milligrams is all what it gives you. And how much is the unit of FFP in terms of volume?
Ma'am, it's 100 ml, 100 to 120.
250 ml, 200 to 250 ml. And how much is your pack cell in terms of volume?
So 250 to
350 ml. And how much is your cryoprecipitate in terms of 1 unit? 15, 20 cc's. And which is better in cases where the fibrinogen is low, cryoprecipitate or FFP?
Cryo, sir.
Because what does cryoprecipitate contain?
What does cryo contain and what does FFP contain?
FFP, sir, plasma is there, and cryoprecipitate are basically
Factor 8, fibrinogen, factor
Cryoprecipitate
factor 30.
fibrinogen. Straight and simple. 10 units, 100 milligrams. You may have a pooled 10 units into one thing, right? So about 200 ml. You have 200 ml you give, you increase by 100 milligrams. Your critical level is, we say target 200, but it should cross 100 at any cost. So that is how it comes to cryo, because you can save on volume. Suppose you have an eclampsia. Let's forget this patient. You have a patient of eclampsia who's gone into DIC. You rather prefer a cryo there because you can't overload them with FFPs. So this becomes a use. In which cases will you use what? And do FFPs require negative positive blood groups, or are they group specific or RS specific? Two.
So they are not blood group specific. Cryoprecipitates FFPs.
And what about FFP?
Sir, FFP is also not blood group specific.
Group specific?
Sir, they are groups. FFPs are also not, sir, group specific.
Okay.
What is massive transfusion protocol? Have you heard of it?
Yes, ma'am. Some transfusion of blood products.
Giving you a
What
hint.
does it involve basically? What?
The definition by
What are the conditions in obstetrics that you can have massive blood loss? What are the conditions that?
Postpartum hemorrhage, ma'am. Placental abruption, placenta previa.
Anything more severe than previa?
Adherent placenta, ma'am.
PS.
Accreta, the accreta spectrum, where you can have massive blood loss. So, do you know any, when is it called massive blood loss? Any criteria?
Ma'am, massive is, ma'am, more than 2 liters, 2000 ml of blood loss is massive blood loss.
So normally it says if you have to replace 50% blood volume within 3 hours or give 3 to 4 packed RBCs within an hour, it's called. And why is a massive transfusion protocol? What is the basis of this massive transfusion protocol?
Ma'am, to restore the circulating volume in the body.
Volume? It's only volume? It's only volume?
No, not only volume, sir. To avoid to prevent the coagulopathies also, sir.
So what is the proportion of components given?
Yes, sir. PRBC to FFP to platelets is 1:1:1.
Yes, so it is basically a protocol or a policy in hospitals for rapid mobilization of blood and blood products. So once you tell or intimate your blood bank that we're getting into this a massive transfusion protocol, they will make arrangements of the entire pack of 5 RBCs, 5 as 1:1 blood components to be made available to the OT. What are the other causes of DIC in pregnancy? Abruption is one. Can you tell us some other causes of DIC in pregnancy?
Preeclampsia.
Yeah, what else?
Intrauterine preeclampsia, ma'am. Intrauterine fetal demise can be one cause.
When does intrauterine fetal demise give rise to DIC? Accepting accidental hemorrhage, say IUFD just happens. Does it give rise to DIC immediately?
No, sir. It takes some time.
Some time means how long?
Sir, 4 to 6 hours.
No, absolutely no. It takes about 3 to 4 weeks before it starts consuming all the clotting factors and all. So doing a hurry and doing all the blood coagulation profile in every 6 or 8 hourly is something which is totally wrong for IUFD, for an not accidental hemorrhage based, but other IUFDs. Yes. So because basically in IUFD, the fetus, the dead fetus consumes all the clotting factors and it takes time. So it's not immediately that it happens, right? But when I don't know whether you have been able to see something like a second trimester abortion with intraamniotic saline.
That is all gone.
Days it used to happen. So that was one of the reasons of DIC. Yeah. But for the most ominous is the amniotic fluid embolism, which can give rise to DIC.
Yeah. So postpartum hemorrhage and amniotic fluid hemorrhage, septic abortions, okay, all these conditions can give rise to DIC apart from abruption.
Okay, let's hear what she has to do over her patient.
Sir, first I would like to secure 2 large bore IV lines, restore the airway, breathing and circulation if the patient is not maintaining the saturation or anything. Then I would like to transfuse blood and blood products to her. Confirm. First, I would like to confirm the blood and blood cross match, and then immediately transfuse her, and then take up the patient for the emergency lower
So
segment.
for resuscitation, what are the IV fluids which are used?
Colloids and crystalloids, sir.
Which one is first?
Sir, first I would like to crystalloids.
Yes, always remember that, right? Colloids have a diluting factor on the blood levels. So subsequent to that, if you send your sample for cross matching, they'll find it very difficult to do a cross matching. So therefore, all the samples have to be collected, and the crystalloids have to be given. And in crystalloids, what would you prefer to restore the blood pressure immediately?
Sir,
It's normal saline which we'll use first to bring up the blood pressure, right? 1 or 2 units of normal saline should bring up the blood pressure, and then you can start with ringer lactate and other things as such. But use crystalloids first, that's most important. Yes, go ahead.
Sir, then transfuse with crystalloids, and then transfuse blood and blood products, and then take up the patient for emergency lower segment cesarean section.
Okay, that's what you did?
Yes, sir, that's what we
Okay.
did.
So what were the precautions taken at C-section? Your baby is live, right?
Yes.
How did you go about a C-section?
Delivering the baby immediately, faster is the main goal, because I don't want to.
Would you take a vertical incision or a transverse incision?
So vertical incision would be better for exposure.
Why do you want exposure?
I think it's subjective better. Some people are faster with vertical, some I think it leave to the surgeon. Some
Yeah,
people
but most of the times, I mean, what are you used to? Gayatri, what are you used to doing?
Sir, lower segments is
Yes.
transverse incision.
So I think that is fine. But if the fetal sons are dropping and if the patient is not really in a good shape, maybe then vertical would be justified as such. But I would still resort to whatever I'm doing as a regular matter as such. It doesn't take more than a minute or so more than that transverse, the vertical incision as such, right? But the post-op recovery and other things is much better with the transverse incision.
Yes.
Yeah. Okay. Then how would you deliver the baby? Baby, supposing if it is, by bridge.
Sir, if the baby is breached, then the buttocks I would like to remove.
Okay, that's fine. That's fine. But your baby, your patient was encephalic?
Sir, yeah, it was cephalic, sir.
So how would you deliver?
Sir, deliver
Nothing specific, right?
nothing. Yes, sir.
Okay. What is more specific subsequent to that?
Sir, removal of the placenta along with the clots. Whatever clots are there in the uterus, I need to remove them properly, sir.
How would you how much how do you quantify the clots with the blood loss?
Ma'am, if it is less than 150 cc,
No, how do you? Matlab, you have like say you
Grams?
measured the clots, right? So you have 50 grams clots. So how much blood loss is that?
50 gram can be, ma'am, around 500 to 600 ml of blood loss.
Is it? Normally the clots that you have is equivalent to the ml of blood that there is. Okay. Can you tell me, in any case of section, how do you do a quantified blood loss? How do you quantify blood loss? Because that is important in all these cases, right? When you're talking about postpartum hemorrhage or abruptio placenta.
Ma'am, less than 500 ml is considered normal, ma'am.
Yeah, but how do you quantify your blood loss? I mean, normally, what is the method of when you're doing a quantified blood loss or trying to estimate blood loss at a cesarean section?
How do you collect the blood at C-section?
Sorry, sir.
How do you collect the blood?
So separating the clots and
No. Right, during a C-section, how do you collect the blood?
Suction.
Exactly. So you measure the suction, right? Yes. Besides that, what else?
Whatever clots are there after removal of placenta, if we have collected them separately.
Besides that, what? Do you use mops?
Yes.
So
normally when you're doing a quantified blood loss, ideally when in a section, especially when in a section like this where you would want to quantify, you normally look at the suction bottle immediately after delivery of the baby, because anything in the suction bottle before delivery is the amniotic fluid. You minus that from the total volume of blood in the suction. To that you will add the clots that you have seen, and to that all the amount of mops that you have used, the drapes which have normally, if you are doing a proper quantified, you have to do the wet mops minus the dry mops weight, which we are not. So we are doing a visual estimation, but in a proper quantified, you need to know what is the weight of your dry mops and then measure all the wet mops so that you can minus. So when you add all this together, you get a quantified blood loss. But these are the cases when a proper estimation at cesarean section is important so that you can adequately replenish or the blood volume and the blood products. Gayatri, what would be the advice to this patient for the next pregnancy? She's para 2 living 2 now, but had she been, she wants to have another pregnancy, what would be your advice to her?
Since she's a known case of gestational hypertension, so risk of hypertension in the next pregnancy is also increasing, and then we also need to explain her the risk of abruption in the future pregnancy also, and folic acid supplementation in the next pregnancy. Early antenatal care registration is important.
Gayatri. Hello, Gayatri.
Yes, sir.
Suppose in this pregnancy we find out the cause as a PIH or a pregnancy-induced hypertension as a cause of abruption. You find out. Clear. Very good. What are the strategies of prevention of PIH in next pregnancy, so you can prevent abruption? Right from the inception, day one, she's come to it 8 weeks till she goes. What are the strategies you will find out?
Sir, first if the next pregnancy she has come to us for registration, we will first counsel her about the risk of hypertension in this pregnancy. Then we will start EcoSprin for her 150 mg OD from first trimester itself. Then we would like to do a PIH profile for her, see her routine labs, her LFTs, her creatinine levels. Then do an end organ workup, do her ECG, a 2D echo.
What is gestosis scoring? What is pre-implantation or pre-pregnancy counseling you will do for this patient? Like before she conceives, what are the counseling point, and what supplement you will give to this patient, and what is gestosis scoring?
Folic acid supplementation, sir, we will start before pregnancy itself for her.
Okay.
And
okay. How will you screen PIH? What are the methods of screening of PIH? What are things you get? First is gestosis scoring. Second,
the screening of PIH, sir, in first trimester we can do first trimester screening, sir. We will do an NT-NP scan for her, see for the uterine artery PI, sir, and dual marker PAPA levels of less than 0.5 MOM are more likely to have preeclampsia in the further stages of pregnancy.
Okay, then.
And sir, do a routine liver function and kidney function, the creatinine levels and all we will see.
What is the ideal time to start EcoSprin? Suppose you get a gestosis score of what, you will start EcoSprin? What is the score cutoff? Gestosis score?
3. 3, sir.
3. Okay. So when you start EcoSprint, how early you can start?
So from 6 to 8 weeks after
6
confirming
to 8
the
weeks.
guidance.
Why so early, and why not at 16 to 18 weeks? Why at 12 weeks, or why not at 16 weeks? Suppose you come at 16 weeks, 18 weeks, then whether the EcoSprint will help for prevention of PIH, and if not, then why? So why you start early?
After 16 weeks, it is found to be of less beneficial value.
Why? Yeah, correct. You're right, Beta, but why?
Why?
So what is the primary and secondary wave of placentation? So when the placentation happens, first wave, second wave, and why not after 16 weeks it will help if you study EcoSprint?
Because the trophoblastic invasion has already been taken place.
Second wave has happened. Second wave already gone through. Yeah.
Yes.
Then go ahead. Then what are other tests of screening PIH?
Sir, in second trimester, I would like to see for a uterine artery Doppler at 28 weeks of gestation, sir. Uterine artery Doppler, sir. Doppler, sir. To see for the umbilical and uterine artery flows, sir.
Then?
And
Madam has told something about last lecture about angiogenic and anti-angiogenic factor. Angiogenic and anti-angiogenic
and anti-angiogenic. Yes, that's right.
SFL2, SFL1 upon, and yes, they are all endoglines.
Yes,
VGF.
VGF. Yes, sir.
So what are the good, like, so you like the VGF? Yes, very good.
Protective, sir.
VGF angiogenic. Yeah, correct. So VGF and PGF are angiogenic, and anti-angiogenic are SFLT1 and endoglines. So the importance of this are the ratios. So then what is the ratio? Cutoff ratio? The ratio of what?
SFL.
Yes, SFLT1
to
PLGF upon
SFL2 to
1.
LGF. SFLT2.
Yes. So what is the ratio?
How much will the ratio be?
Ratio B, cutoff. Have you ever seen the report, Beta?
Yes.
Have you seen the report, and what is okay?
So it should be less than 85.
Yes.
100
is the cutoff.
That ensures that the pregnancy is going to be fine. It has a good predictive value.
Yes.
Anything between 85 to 110 shows that the possibility of development of preeclampsia, right? But more than 110, the possibility of development of preeclampsia after 34 weeks is very, very high.
Yes.
I have a question.
Yes. And there is
go ahead.
Yes, sorry, ma'am. Yeah, so Beta, again, that there are two trials you should know when you like screening for PIH. 2 trials. What is the FIGO-HAP protocol? You know what is FIGO-HAP protocol? I did not see this. FIGO protocol, NCD project. These all things you should know. It take care of MAP and maternal factors. FIGO protocols, FIGO-HAP protocols. You know about, you listen. See, there are certain protocols, certain trials in PIH you should know, because this topic is linked with PIH and abruption. Because most of the PIH become abruption. You don't get other causes. Now, it's not in our patient what we see in BMC corporations. So you should know certain trials you should know. That is, one is FIGO-HAP trial, one is ASPRE trial you should know, one is Paris trial, one is pre-trial. These are all trials you should know. If you're doing well in your exam, the examiner of South India people, they ask all these trials. So go through the books, go to the FIGO trials, okay, Beta, and they will answer everything good. Yeah, ma'am, you can ask question, ma'am.
Yeah. So I just wanted to ask one question, clinical to Gayatri, and of course inputs from the other seniors here as well. This patient, suppose, has had a massive abruption at 35 weeks and had an IUFD in her previous pregnancy. What are the precautions you're going to be taking in her next pregnancy, and when would you plan delivery for her? Of course, you have started her on aspirin and, taken all that, but now when would you think that would be an ideal time to deliver this patient? She has had a massive abruption at 35 weeks in her previous pregnancy.
So I would like to, ma'am, first stop aspirin for her from 32 to 34 weeks. I would like to stop because she might again have an episode of abruption in this pregnancy. And ma'am, do a routine.
Agreed upon that if you have had a previous abruption, the chances of having a repeat abruption in next pregnancy are also high. Right? So what advice would you give her, and would you consider early hospitalization or?
Yes, ma'am, I would consider, and if any bleeding or any episodes are there, we need to reassure her and tell her to come to the hospital immediately if she has any spotting or bleeding episodes in this pregnancy. And tell her to regularly monitor her BP.
Sir, Dr. Rajkumar or Dr. What would be the ideal time to deliver such a patient? This is just from the clinical point of.
In the previous pregnancy, probably she was not as well monitored from accidental hemorrhage point of view. Now, in this pregnancy, since you know for sure, I think we'll have to work up in between two pregnancies to find out if there's an underlying cause. For example, antiphospholipid antibodies or thrombophilias as such, And if that's the case, then probably we can put them on aspirin and heparin as such. Although these days thrombophilia has been taken out as one of the contributing causes for accidental hemorrhage. So therefore, antiphospholipid antibody still remains as one of the important causes to find out as such. So if this patient is covered well with aspirin and heparin till 35, 36 weeks, I would definitely deliver by 37 weeks. I will not still, just because it's happened the previous pregnancy, it doesn't mean. Of course, maybe we'll keep her under watchful expectancy from 35 to 37 weeks, but not above 37 weeks that it should be allowed the pregnancy to go.
Right. So very monitoring between 34 and 37, that is the time when she had abrupted in a previous pregnancy. So you would keep a very close watch on all her parameters and then deliver at 37 weeks. That I think is a fair.
Now, what are the precautions you will take during LACS of a patient who is just LACS of this patient? Suppose she has IUFD and she has almost lost 1 liter of blood, because IUFD you lost around 1 to 1.1 liter. And mother is going in DS, you put the catheter and the blood pinch has come, and you take a section. So what are the problems you anticipate, and how will you handle these problems during LACS? During she's not there. Yeah, correct, doctor.
Sir, during LACS, we need to continuously look at her BP also, since she has a massive blood loss, sir. So the BP can drop.
And ongoing hematuria is there. Hematuria started, and you take a section because she's having the hematuria. Okay. Now how will go ahead?
So we need to continuously transfuse her throughout the surgery.
Correct. So what are the problems do you anticipate during LACS, and how will you handle that problems? See the primary gravida 34-week IUFD, section, hematuria is there, massive transfusion protocol followed. You are giving her everything. So what are the problem can come during LACS, and how will you handle that? We don't want to remove the uterus at any cost. We want to conserve the uterus.
You expect the uterus to become hypertonic?
Sir, tone might be, the uterus might become flatty.
No, we say that all covariates are
restoring the tone is difficult in this.
So not all covariates are atonic, but some of them are.
Yes.
So be ready with your mindset that, well, she may bleed. I need to have A, B, C, D, E in my hand.
Yes.
What is that A, B, C, D?
Yes.
What will you keep ready with you? For atonic
uterotonic. Sir, we cannot, we have to immediately give her pitocin or carbitocin. Misoprost should be ready in hand, sir. And methergine we cannot give since she is a non-hypertensive patient.
I would just one interruption. You're right, but in your exam, please avoid using use a generic name. So don't use pitocin, use oxytocin, use ethylergometrine. Okay, use it just avoid using generic trade names at all. Yeah, go ahead, Kath.
So ma'am, I will keep misoprost ready. And
how will you give misoprostol to this patient?
Sir, now sublingual will be better since we are operating. Sublingual 200 we will give first. And
when do you expect the action to start?
Sir, sublingual it will start within 5 minutes.
Yeah, around 10 minutes. 12 minutes, yeah. The peak comes within 20-25 minutes, but...
Can you put a misoprostol and start LACS? Can you put that forward and start LACS? Prevention of... Can you start? I'm asking you.
So there are some which do that in order to...
Yeah. Yeah.
We don't do it at our place, but I have
Yeah.
seen this.
Yeah.
For
Or maybe you
rectum,
can go.
for rectum misoprostol.
When will it act? Suppose we're giving 1,000 micrograms of misoprostol rectally.
For rectally.
When do you expect it to work? How many minutes does it take for the onset of action per rectally?
5 minutes, 10 minutes.
Sir, I think it's 15 to 20 minutes per rectally. Sublingually, it will act faster.
About 30 minutes. It's not magic. It takes about 30 minutes.
30 minutes.
Orally is about a couple of minutes more than sublingual.
Yes.
And vaginally also. But all they have a longer duration of
Longer.
when you use them. The oral one is in fact 3 hourly, vaginal becomes 4 hourly when we use it for this thing. So you increase you get the duration of action in the other routes. And of course, the efficacy is faster with sublingual. And we don't have 800 there. I think 200, 400 is good enough. Otherwise, many of my patients get dry gulls which cannot be stopped with any drug.
Any drugs.
Yes.
Okay, you are given misoprostol, prostate, and what everything is done. You are given everything. Uterus is still hypertonic, atonic. Patient is still bleeding. You are from one side you're putting packed cells, other side FFP is going on like water. What next will you do? Uterus is atonic.
Sir, I would consider doing Beeling sutures or uterine artery ligation in this case in order to restore the tone.
So we'll do uterine artery first or Billings first? Or you'll do combo utero with Billings together?
First means if either you do one of the two or you'll do both together.
One. Sir, first.
So first you will do Billings or first you will close the uterus? Or you will do Billings and then uterine or uterine and Billings together?
Sir, first uterine artery ligation followed by Billings.
So first you will do stepwise devascularization of the uterus. What sir do RMS sir has shown us in the conference. So we'll do uterine artery, we'll not take ovarian. If possible, we'll go for right side internal leg, which can reach fast. And then you see the uterus, then you do a Billings. Okay, then what else? What else you can do? How can you check that patient is still bleeding? You see, you're not knowing that she's bleeding or not. And you are operating. But she's still bleeding. How will you come to that? You see, all copulae are not, as sir told, all copulae are not bad uterus. Only 10% copulae are bad uterus. So that 10%, how will you catch the 10%? How will you check that she's like after your stepwise, after internal leg, after Haemorrhage or Billings, she's still bleeding, and you want to close the abdomen? If you have seen, you will answer.
Sir, in such cases, internal iliac ligation can be.
Yeah, we are done. We are done the right side. We are done.
See, let me make something very clear to you, my dear. Internal iliac ligation is not a panacea for upper PPH.
Yes.
Uterines work as well. And let me tell you, the best of hands, you'll do your uterines faster than you'll do the iliac. Time matters here. Remember, the uterines done well will give you 70% protection. Iliacs will give you 50, 60, 70 at the most. I get it. But you have to hit the uterines well. And where to ligate becomes the most important question.
Most important.
If you put on stitch uterine lalii, that doesn't work that way. You have to learn the right technique. Now, in spite of all the things put together with the best of B-linges, your Haemans you put it, if you still trickle, beware, this is a case of still DIC continuing. That becomes the problem whether you proceed with a hysterectomy or not. That's where it goes to. So, in spite of the best things you put in, your best of B-linges, everything has been, your entire uterus has been compressed from every side. You got sutures like this, you got sutures like this. But what next? So then you come to realize that still it requires correction and you may end up in an obstetric step, which is not going to be easy because bleeding can come from the stumps also. It's deadly. I can tell you it's deadly. By the way, what is the incidence of DIC in abruptio cases? Severe abruptio cases? Severe. Let's talk the severe ones. What is the incidence of DIC? How much can you anticipate? Is it more than the other? Of course, it's much more than the other the causes of DIC in obstetrics. Almost 30 to 50% can get DIC.
Sir, in concealed type,
more chances.
More chances.
Severe cases are those 3B. The ones where you have an IUFD with the mother who is very moribund. So those cases, you have to be on your toes. Believe me, this can really go wrong. And this is the consumptive coagulopathy, massive. The clot has taken everything the mother has. So it becomes a little dicey thing. But yeah, you as you
Now,
right,
yeah, yeah.
come them early and don't hesitate to do sections, please. Don't get carried away by one vaginal delivery. Slide out, baby's alive, get that baby out. Finish. 70,
Yes,
80, 90 heart rate, get that baby
get
out.
out. Yeah.
You baby, you see the baby of cord compression 80, 90 will behave differently than the baby of 80, 90 here. Because
Not
this
the time.
baby to some extent gets exsanguinated also in abruptio as compared
Yes.
to placenta previa. There is a little extra bleeding of fetal-maternal hemorrhage. So these babies at 70, 80 may be bad as compared to your 70, 80 of fetal distress not related to abruption. So you have to get that baby out. Then, of course, your abruption, your DIC gets in fact negated because your baby is out, your placenta has come out. So the patient doesn't go into DIC. So it has to be very, very quick. Decision making, clinical, as she said. There is no sonography here. Touch
No
the arm,
sonography.
started bleeding, decide. Blood ready, take the patient to the theater, finish it off. Prematurity is no big deal, ma'am. 30, 32 weeks, get the baby, save the mother. That's it. I'm going to deliver vaginally. It may take 6 hours. That all looks good on books. But when it comes to all this decision making, an extra section save a life, worth it.
Yes. So if you've diagnosed abruption and baby's heartbeat is there, you need to deliver this baby as and if you have an IUFD in a term patient with abruption, you know that it's already a severe bleed. You need to ask for blood before you actually, wait for an hour for the coagulation profile to come. Because that time is going to be crucial in her going into DIC or being resuscitated.
Nimish, how
Yeah.
long do we
One
have?
more.
How long do we
So we are just with 2 minutes, 2 more minutes to have 2-3 minutes. 11:56 we'll close and for next 4 minutes. Sir, last question to from my side. Suppose the day was good and we able to save the mother and uterus. So now what are the long-term sequelae of this patient? Long-term sequelae, doctor? What long-term sequelae she's going to face in postpartum and morbidity with this patient? She's there. I think she's not there.
So immediately after consumption, she might have a decreased urine output. Then there is a risk of.
What is the commonest thing? We are given a massive transfusion. Patient was having hematuria. So what all long-term prognostics will have, and what even monitor this lady in the postpartum period, and after discharging home. Long-term body can have 1, 2, 3, 4. See, she is a mother who might go to SICU, ICU, HDU. So HDU related problems. Second, she can have AKI. So you have to monitor creatinine. She should not require long-term hemodialysis. All things this patient require. Third thing, what she can have is a massive transfusion. She can have apoplexy, pituitary apoplexy. She can go in Sheehan syndrome. So all these factors, postpartum depression, anemia, infection, sepsis. See, we have just, it is not our role to just take her out of the deathbed, but also to make a normal life. So to monitor all these things, okay? Correct?
Yes.
Sir, I think the time is over, sir.
Okay.
If any question from anyone, sir?
I think
She has done good, sir.
good job. More than enough has been covered with, I think,
Yes.
Yes, sir. Yes, sir.
And she's done really well. We have literally
She's very good.
Keeping
you
having
have really bombarded her. You have really given it. You come all set to, I think, to get it. Anyway, well done. I think it was a very, very fruitful discussion. Trupti, so very nice of you to contribute. We're happy to have you on the RAN platform, and so very nice of you to join us.
Yeah, it's been lovely. Thank you for having me here. And really, I think it is a boon for the residents. And I think, more and more, residents and PG students all over Bombay should be.
We were only worried
attending.
about the number of residents who are joining us because we have to get that number of students who are actively, who will be going through the exams. What has happened over the years, we don't have the bank updated. So the ones who have gone through RAN, have passed out and are practicing also may still have the numbers on RAN. So that is one thing we need to do to spread around. We'll work on it. Let's see.
Trupti, this is just a request from AFG basically that, just inform all your colleagues there in Wadia as well as other teaching hospitals that encourage more residents to join this. This is completely free. This is on a Sunday morning, which is more convenient. And they are open to present cases, which is, something like a discussion, like an exam kind of discussion.
Absolutely. And I think it should be done right from it's not only when they're exam going, but right
Yeah,
from,
exactly. So it's
from the
ongoing.
first,
It's ongoing.
they kind of get
Yeah.
tuned into this. Absolutely lovely. Gayatri, you did well.
Yes, very good.
Wadia has been the alma mater for me and Rajkumar also.
Yeah.
So very, very close to our heart. So that's where it comes down to.
I think almost everybody has had some, this with Wadia through their, in early years. So
Anyway,
lots of
thank
changes have happened now. You all must visit.
Yeah.
Well, I was unfortunate. I'd come to Wadia about 6 months back, gone to KM. Me and Dr. Karthik Bhagat said, let's go to Wadia. It was, I think, a Sunday or, it was a Sunday. So we went to the RR gate. I said, let's go up and look what the labor room looks like. The security told us, no way, we can't allow. We said, we've been here in our 90s. He says, no, we can't allow. We go to the office, take permission and come. So we said, the office is closed. Sorry, we had to. So we went back to the gate. Then we said, let's look at the RMO quarters where we struggled for days together and we stayed. They said नहीं लेडीज हो गया है पूरा. I said चलो यार स्टेयरकेस पे खड़ा करके देख रहे तो कोई बीच का कंपाउंड कैसे दिखता है. मेरा रूम
That's not in a very good state right now. We are kind of working on it to get it.
I wish we could have walked across the alleys and all that, but anyway, someday we'll take permission and come. That's the only way.
Yeah, surely, sir. I mean, absolutely. Whenever you come, you're most welcome. There have been a lot of, because right now it's being converted into a super specialty hospital for women. We are, introducing other fields as well. So they want to, or not only mother and child, but they actually want to make it a specialty hospital for women. So
our RR, our 1 and 2, ward 5 and 6, all those PNC wards, all those memories come, to us. What a time we've had. Anyway, what's the delivery rate in your hospital at the moment per month now? At Wadia now, approximately confinement rates, confinement numbers?
Confinement would be around 800 now per month.
We used to have about, on an average, 40 to 55 deliveries a day that time. This was in 90s.
Now it will be about 20 to 25, but we have now a lot of preterms, lot of patients coming for NICU. So the number of NICU is flooded with all the 27, 28, 30, 32 weekers which are coming from all over for the NICU.
Yeah. So anyway, that was a hard time, and we used to only have 3 residents, juniors, supernumerary, junior, and senior. 3 residents, 1 registrar. 4 people in the unit. That's all we used to. I don't know what the strength is now. Anyway, chalo, thanks. We'll catch up some other time on the RAN panel. Thanks. Have a good Sunday afternoon.
Okay, sir. Thank you, sir. Yeah.
Thank you.
Just also thanks everyone. Yeah. Just thank you everyone. Yeah.
Kansara is very quiet. Kansara, thanks for joining in. Yeah, you'll be happy to have you on the RAN platform.
Yeah.
Thank you.
Thanks,
Have
sir.
a
Thanks,
good day.
everybody.
Bye-bye.
Bye.
Bye.
Bye-bye.
Bye. We'll close down, no? Yes.
thank you so much everyone for joining this session. Planet is really glad to have all these brilliant people together. So with this, we are closing the session for today and looking forward to hosting you again.